Thank you, everybody, to be here. I think it's something, amazing that we can be at least in presence again. And, for us, it's a really great pleasure to have the possibility to see everyone in person. Is kind of a dream for us. And I think this is really a moment of emotion that is going to be along us for 3 days. And I'm really happy to say that I would say thank you for all of you to come and to take the opportunity to restart, to have physical contact. Although I think that the most important physical contact will be Saturday morning, right? That will be for sure a kind of real physical contact. But I hope that this is really the restart. And I'm sure that we had really terrible period, but now we are happy to be here again. And this is the 14 times that the great meeting is be held. And it's really something that we cannot believe in 2007 when we start here in Rome, the first meeting. I'm really glad that although the pandemic was so bad, we still continued to go in making research. And the fact that here today we have to go present important topics that are the results of 2 days of working is still, making the reality that the great network is really there. And thanks to young people that are the spirit of the great network, we are able to go ahead and publish together. I don't want to take too much time because we have a lot of pressure. I'd like to thank you, especially to Christian, for set up this unbelievable program. That for sure will be the way to do something good things today, but also in the future. Thank you again to everyone to come.
Well, I'm supposed to give the second welcome speech, just to say that it's really incredible. I guess first, many of you were, if not all of you, were in the first line in the COVID period, taking care of many patients. And I guess many of you even didn't think that we could meet together. And it's just incredible, a lot of emotion to be again all together. We are going to see so many presentations. You may still have seen in PubMed many papers coming out with a great network. We'll maybe talk this during the General Assembly, but probably we are not far from 100 papers since the beginning, which is really amazing for the young generation. And again, I'm so happy to see all of you here, and thank you for all the efforts. And now, for sure, compared to 2007, now a large part of the scientific community knows what is the great network and knows that it is a network that is here to push the youngest and the youngest who are becoming a senior now, but we have a new youngest, and really it's just a great moment. And I think the other great moment of this conference is going to be the soccer game. And we hope that this time finally Italy can win after all the years where Christian and myself were beating the Italian delegation. But this year maybe we can do Christian a small exception and let them.
Don't find the excuse.
Okay, but again, we are so happy to see all of you, and I guess Christian will talk about the competition and the awards that we will deliver, and it's really one of the most important point of, and we had it from day one, and again, it's really so great to see all of you here, and bravo to all the young generation.
Welcome all. I'm not going to speak for long, but it is wonderful to see you all, even though some of you behind your masks is pretty difficult to identify, but I am spotting you all. It is great to have a genuine in-person meeting, and I'm really looking forward to the discussions and collaborations. I'm not going to mention the football after Scotland's performance the last time we met in person in Edinburgh, which was a wonderful occasion. I'm going to focus your minds on the evening in the castle rather than the 7-0 dropping or whatever it was in Peppermill, but lovely to see you all.
So I think all important things have been said. I'd like perhaps to add only two. Of course, also welcome from my side. As Salvatore, Alex and Nick mentioned, so this is a meeting specifically dedicated to you, to the research fellows that are the key persons that drive the projects. And so this meeting is devoted to you. It should provide, and it will provide, a fantastic opportunity for you to either for the first time or one of the first time present your work, to have an audience that is interested in your topic, that discusses the topic with you. But also, if you are working in a research group and you're not on stage this year, but then you're here to support your colleagues who present your work that all of you have worked so hard over the last months and years. So the spirit of our meeting is, I think we try to have the best possible combination between competition and fun. We try to live this ourselves. We try to live this combination between competition and fun on the football field, but also here. And therefore, as mentioned, we have a competition among the best presentations for the research fellows. Again, there's a committee that is led by Danielle. So Danielle, if you identify yourself, so she's Danielle has volunteered to again chair the committee. There are other experts in the committee representing the different countries that may contribute to this meeting, to make sure that we have a very fair and very transparent evaluation of all of the presentation. So that's again was possible mix between competition and fun. This meeting is devoted to the fellows, but also it's a meeting, I think, that nicely highlights the very nice interaction that in our academic setting, we as academic investors have with partners in the industry. A lot of the innovation that we evaluate in our studies, I mean, this innovation is only made possible by fantastic efforts and achievements in the industry. Therefore, also this meeting is a wonderful interaction between experts working in the industry and experts working in academia. And I think there are a few areas in medicine that I'm aware where this interaction, I think, is so fruitful and beneficial also for us as academic investigators. And so I'm very, very thankful, first of all, that several companies have agreed to support this meeting. But I'm particularly thankful for those who have decided to also have an active representation here, who are with us, and even more so the two who will actively share their latest developments within our program. And one expert that has been closely working with, I think, all of us in the past, but also with many of you in the great network has been Dr. Gesa Alpert from Roche. And so I'm very, very happy, Gesa, that you are here with us. I would like to ask you to come to the podium and start the first session of the meeting, which is called State of the Art Technology. And so we will have two presentations from key experts from the diagnostic industry on latest development. And the topic of Gesa is addressing the unmet medical need of perioperative myocardial infarction and type 2 diabetes or myocardial infarction, an industry perspective. Thank you.
The YouTube, you are now. Okay, super. Thank you very much, Christian. Thank you all. It's a great pleasure for me to be here today. And yeah, we would really not have thought that this is possible to meet again in person this year. So it's my first time that I'm not sitting in front of the screen, but here with you. And I think for a lot of you guys as well. So really great pleasure to have you. Okay. Okay, so my title is missing anyways. My name is Gisa Albert. I'm indication lead for cardiology at Roche Diagnostics. And today I would like to talk to you about two claim extensions we've been working. So this is now something we launched in our package insert just this year. And this is on one hand about perioperative myocardial infarction in non-cardiac surgery, and also the role of NT-proBNP in type 2 diabetes. So let's get started with a couple words about troponin and its role it plays in a myocardial infarction/injury. So most myocardial infarctions occur within the first 48 hours after non-cardiac surgery, where patients are receiving analgesic medications and therefore their symptoms are masked. And this is why it's very difficult to really detect these. Studies from the Vision Group in Canada, but also by Christian Purlacher and Danielle from Christian Müller's team, have been shown that elevated high-sensitive troponin T is associated with an increased 30-day mortality rate after non-cardiac surgery. So routine troponin monitoring can on one hand detect patients at a marked increased risk of death within 30 days. And it has been shown that increasing mortality rates are associated with increased absolute deltas, but also postoperative elevations of high sensitive troponin T. So routine PMI monitoring may provide an opportunity to improve the postoperative mortality. This has already been also taken into some of local and regional guidelines. So as you can see in this slide, starting in 2014 until 2018, it has been shown to be taken up by EC guidelines, but also guidelines from the European Society of Anesthesiology, but also local ones such as the Brazilian guidelines and the Canadian guidelines, where it has been suggested to monitor with troponin post-surgery, and in some cases even taking baseline level. In our package insert, you will see two expressions. It's on one hand MINS and on the other hand PMI. And I would like to go a little bit into detail the difference between the two. So there's on one hand myocardial injury after non-cardiac surgery, and that one is defined as elevated postoperative troponin measurement resulting from myocardial ischemia during or within 30 days after non-cardiac surgery. So when you're looking on the graph, and I heard that this pointer is not working, so I think, but you'll see it anyways, MINS is really addressing type 1 and type 2 myocardial infarction. Perioperative myocardial infarction with PMI is defined as an elevated and dynamic postoperative troponin without requiring ECG or symptoms. And that one is broader than MINS. So it is also addressing cardiac-related causes such as acute heart failure or tachyarrhythmia, but also extracardiac causes such as sepsis and pulmonary embolism. So it's basically covering a huger or larger representation. So where have the cutoffs been derived from? The MINS cutoffs have been derived from the Vision study, which looked at more than 20,000 patients. And here, elevated postoperative troponin was defined as a MINS if the absolute or if the troponin level was between 20 to 65 nanogram per liter with a change of more than 5 nanograms, or if the elevation of troponin was above 65 nanogram per liter. For the PMI, these were derived from data from Christian Purlacher. And here we're looking at the baseline level preoperative and the post operative level. So here, if you're having an absolute value of more than 40 nanogram per liter, which is represented in the 99th percentile, between pre and post, within this, the first 7 days after surgery, that is considered as a PMI. So here I'm already kind of summarizing the first part and giving some perspective. So in the fourth universal definition of myocardial infarction, the expression of myocardial injury was defined for the first time, and that is very often related to PMI. So recent guidelines recommend the measurement of troponin within the first 48 hours after non-cardiac surgery, really to identify high-risk patients for early response and close monitoring. It has also been shown that natriuretic peptides, such as NT-proBNP, play a very important predictive role for 30-day mortality. And first studies are now analyzing how TNT and NT-proBNP work together preoperatively, and we're very much looking forward to these studies. Now I'm right away jumping over to the second part, which is addressing the role of NT-proBNP in cardiovascular risk assessment for patients with type 2 diabetes and optimization of cardioprotective treatment. I think I do not need to convince anyone that diabetes is really considered as really one of the biggest epidemic challenges we're facing in the future. Already now, or in 2019, there was a prevalence of 463 million people worldwide suffering from type 2 diabetes. And by 2045, we're expecting more than 693 million people to suffer from type 2 diabetes. And especially in middle income regions such as Middle East and North America, but also in Southeast Asia, the numbers are increasing tremendously. Heart failure and type 2 diabetes are sharing common risk factors, and it has been shown that patients suffering from type 2 diabetes also very often develop heart failure. So in a study where patients with type 2 diabetes have been screened, they also measured NT-proBNP here. And they could see that when using a cutoff of 125 picogram per milliliter, that serves as a really good predictor for hospitalization of heart failure. So as you can see on the right-hand graph, really this cutoff of 125 clearly significantly discriminates patients with increased risk for heart failure hospitalization versus those that having less than 125 picogram per liter of NT-proBNP. So here, NT-proBNP cutoff of 125 show a good discriminatory ability in patients with and without a history of cardiovascular diseases. So in 2019, a team has been already shown a practical approach how that could look in clinical setting. So when we're looking at clinical factors that are associated with the incidence of heart failure, there are diabetic specific factors such as insulin use, duration of diabetes, but also vascular diseases. Then there are cardiovascular risk factors such as hypertension, obesity, and atrial fibrillation, and non-cardiac risk factors such as increasing age and obstructive sleep apnea. So it is recommended, or like here they suggest to measure NT-proBNP in all of these cases and kind of monitor it. If the NT-proBNP is below 50 picogram per milliliter, you would just continue monitoring but not start treatment. If it's above 50, it has been suggested to start SGLT2 inhibitor treatment. So with the use of NT-proBNP in combination with risk factors, it might help to identify patients that are suffering from type 2 diabetes to understand which one might benefit from the usage of SGLT2 inhibitors. So a couple scientific messages about this part of my talk at the end. I hope that you could understand that heart failure is really a common cardiovascular complication in type 2 diabetes. So cardiovascular disease risk stratifications for type 2 diabetes is important on one hand, really to reduce the burden of the disease, but also the healthcare costs. So I didn't show you the slide here, but we analyzed the healthcare costs that we might be facing in the future. And these are really tremendous. So we really need to take care of the burden and the costs. I think all of you know or appreciate that NT-proBNP is an established marker for the diagnosis and the prognosis of heart failure. But now it seems that this one can also be used to predict the risk of cardiovascular complications in patients with type 2 diabetes and may help to optimize cardioprotective treatment. So more specifically, especially with most recent trials that have also been shown at this year's European Society of Cardiology Congress, NT-proBNP might identify patients who may benefit treatment with SGLT2 inhibitors. There are currently several large trials ongoing, which are looking at this in more detail. And these are some of these are investigator-initiated studies by Roche. So if you're in any interest in understanding more about that, I'm happy to share that. And also from the recent guidelines, it seems that NT-proBNP in the screening for preventive heart failure is now becoming a more and more emerging, or playing more and more an emerging role. With this, I would like to thank everyone for listening today, and everyone who created these data, which is actually you out here. And yeah, I really also want to thank Christian Müller and everyone else for the great collaboration. I think it's really unique how industry and academia can play together, and very much looking for doing that in the future again. Thank you very much.
Excellent, thank you. So we have time for a couple of questions. Please identify yourself, so then the mic will be brought to you if you have questions for Gesa. Alex, always Alex is the first. Okay, Alex, please.
Thank you, Christian. It's just to say hello to everyone. No, okay.
You forgot to say that.
Now, Gesa, it's really amazing, because it's not an area where we saw biomarker being so important. We understood I like the algorithm with the type 2 diabetes, because it's really practical. I mean, NT-proBNP goes high, and then we immediately need to use a SGLT2 inhibitor, which again, I think it's one of the most important discovery in the last year in medicine, because it works on kidney and many other organs. You didn't have a similar algorithm on the perioperative period. How would you, can you tell us how would you see all the data coming on the perioperative period? How would you translate it in practical way?
Yeah, very, very good question, Alex. Thank you very much for that. With PMI, I think we're still a little bit earlier in the stage. And I think here we would maybe discriminate a little bit between actionability and clinical utility. So I think actionability is something that, for example, Christian Müller's team is looking at the moment. What kind of drugs can we really give to really like reduce the burden for the patient? But on the other hand, if we see elevation already preoperative and also postoperative, I think closer monitoring can already lead to better outcome of the patient. So I think elevations can already really tell you, okay, please monitor this patient closer. And then there might be some drugs. I mean, the MEDAGE trial has been shown that, for example, using dabigatran reduces the risk for patients suffering from PMI. So there are some studies in this context, but we're still in an earlier phase, and there are still more studies needed, especially randomized control trials, to understand that in more detail.
Nick, please.
Just while everyone's getting warmed up out there, you're a fountain of knowledge, and so I couldn't resist the opportunity to ask you a question or two. First of all, I think congratulations on getting this research through to licensed indications. That's extremely difficult. And, you know, as someone who feels that cardiac biomarkers are massively underutilized in terms of their potential, to be able to see that through from the original research is testament to your you and your organization's drive. The question I have relates to Alex's point about the practical implications, which often we get criticized as enthusiasts and researchers in this space. What are we going to do differently? And you suggested there that there'll be ongoing randomized trials in this space. I mean, this link between heart failure, diabetes, and treatment is really exciting area of development. Could you just elaborate a little bit on what trials you think are required in that space or are ongoing in diabetes to demonstrate not just the better outcomes from the application of the treatment, but how the biomarker gets to those better outcomes?
Yes, sure. So I showed you that the prevalence in Asia is extremely high. So there is one big trial that is led by Karen Lamb, where this is the so-called ADAPT trial, where she's really looking at randomization with NT-proBNP with 125 cutoff, and then using SGLT2 inhibitors. So basically, the cutoff alone tells you if you would treat the patient with SGLT2 inhibitors or not. So I think with such a trial where we're really using an NT-proBNP as a as a stratifying biomarker that tells us really for the first time the actionability or not. So I think in the past we've been struggling quite a bit to showing really the actionability with biomarkers, and I mean especially in heart failure we saw a lot of failures. So this is, I think, a little bit kind of getting into a new area for us to hopefully see then benefit and good outcome in this context.
Okay, thank you very much. It has been really great, and we started very well, right? Because at the end of the day, even for the first talk, has been a lot of new insights to think about. That's important. Thank you again.
Thank you.
Now I think we have the second presentation that is from remote, from Maria Patru from Ortho Clinical Diagnostics Company. I don't know if Maria is already there. Oh, thank you, Maria.
Yes, I am.
Welcome.
Hello.
So
Thank you
happy
so
to
much.
introduce you, Maria. She is a Vice Director of Medical Affairs in Ortho Clinical Diagnostics from US. I don't know if Maria is there.
Hello, Dr. Di Soma. Can you hear me?
Hi, Maria. Thank you for being with us. We are really happy.
My pleasure. Very happy to join you, at least virtually.
Can you please expand a little bit your microphone a little bit to increase the voice, because it seems that is the voice coming a little bit less. So
Can you hear me now?
Can you confirm that you are there?
Yes. Can you hear me now? Dr. Di Soma, can you hear me now?
Yeah, not really properly. I don't know if it is a microphone issue or
It might be. I have a very good speaker. I will
start to share the
shout.
screen. Yeah.
Yes, I will.
Yeah, the speaker is maximum.
1 second.
Just need probably you to share the screen with your presentation, Maria.
Yes, I will do so in a moment.
Could we also from here to expand the audio? Okay, they are working to try to expand the audio from you, Maria.
Okay, that's perfect. Thank you so much. Can you hear the screen? Can you see the screen?
We can see the screen very well.
All right.
Okay, now it's okay. Maria is going to talk about again on NT-proBNP, but she's talking about a new performance of the Vitros NT-proBNP phase 2 assay at the ICON cutoffs. So Maria, you can start.
Thank you so much. I really appreciate you having me here. And although I'm presenting data with our Vitros assay, the purpose of the presentation is to actually show the audience performance in the gray zone, something that I haven't seen much of it in the literature. So I hope you will enjoy the presentation. We have two products, two NT-proBNP products. It is the same assay, but we have one in the United States and one outside the United States, and they have different claims. Therefore, I just wanted to point out to the fact that the data that I'm going to share today is data obtained with the clinical trials performed in the United States. Just briefly touching on the myocardial wall stress and how that increases BNP and NT-proBNP. BNP, being the active molecule, is responsible for all the biological effects that you see here, while NT-proBNP is inactive. They are both clear through numerous organs, but also through kidneys. And just pointing out to the kidney clearance, this study actually measured the BNP and NT-proBNP in the renal arteries and veins of subjects with hypertension. And as expected, they saw an equal dependence on renal clearance for both of these analytes. Although you see differences here, the differences are due to the absolute values of the biomarkers. But both of them follow a similar pattern for clearance, and that is clearly affected by decrease of EGFR. Another factor that increases NT-proBNP and BNP is age. As we grow older and, of course, wiser, the biomarkers concentrations will follow a similar pattern for BNP and NT-proBNP and increase. For NT-proBNP, the data that we have obtained on healthy donors shows that in both female and male population, you see this increase from younger. We actually split into 3 groups: younger than 50 years old, 50 to 75, and older than 75. And you can see the increase from the younger age to the older age, with an overall upper limit of normal of 217. We screened the population with the questionnaire and also with troponin, hemoglobin A1C, and creatinine. So we did our best to ensure that the donors were as healthy as we could get them. Now, these age groups were particularly chosen based on previous studies, and I would like to mention mainly the ICON studies. And the ICON studies were performed by Dr. Januzzi and his group, and he actually used the Roche proBNP assays, the previous one, and for the ICON Reloaded, the current one available in the United States. And he validated the rule-out cutoff of 300, which is the cutoff recommended by the European Society of Cardiology for ruling out heart failure in the acute setting. But also he validated the rule-in age-dependent cutoffs. And those are 450, 900, and 1800 for these age groups that I just showed you. Now, in addition to heart failure, there are other conditions that elevate the natriuretic peptides. Now, why this is important is because with the use of the age-dependent cutoffs, you are going to have some areas in between the rule-out and the rule-in cutoffs, which are called gray zones. And it's important for this presentation, but also for the clinical diagnosis, because when these conditions actually increase NT-proBNP or BNP levels, the patients can actually fall into these gray areas, right? Even if you only use the rule out of 300, the increase in natriuretic peptides can confound the heart failure diagnosis. In addition, there are some conditions that can actually decrease NT-proBNP or BNP, like obesity, for example, or other conditions, and that will push the result below the rule out, or in case of the use of age-dependent cutoffs, it will bring the result into the gray zone. This is data from the first trial that we performed, and this is a multi-center prospective study, 20 collection emergency department sites in the US. We enrolled 2,200 subjects, and everybody with a dyspnea, acute or decompensated, and clinical suspicion of heart failure was enrolled. We only excluded terminal kidney failure on chronic dialysis and dyspnea clearly not secondary to heart failure. We validated the age-independent rule-out cutoff and the age-dependent rule-in cutoff in this study. And as you can see from the area under curve data, there is an excellent diagnostic accuracy for all subjects, for female subjects, male subjects, but we also did the analysis for these particular groups that we know are of interest for clinicians. For example, patients with kidney disease and patients with obesity. So these groups are also showing a very good diagnostic accuracy. Now, the same data analyzed differently, just so we can look at the sensitivity, specificity, NPV, and PPV, with an accent, of course, on NPV and sensitivity for the rule-out cutoff. But also, I want to point your attention to the specificity data you see that with the use of the age-dependent cutoffs, the specificity increases significantly in our study, which is expected, right? Because you are increasing the value for the ruling. Now, what that data doesn't show is the gray zone. So although it's the same data, we arranged it differently to point your attention to the gray zone, and mainly to the fact that for all subjects and for every single of these groups, you can clearly see that 2/3 of the patients right here in red with results in the gray zone do not have heart failure. So 1/3 are diagnosed with heart failure. The 2/3 do not have heart failure. And this is important because as a clinician, you have to consider other causes. That result is not just negative for heart failure, is negative for heart failure, but positive for other conditions. Again, same data, but this time I wanted to show you the likelihood ratios for all these groups. And in addition, I wanted to show in this diagram something, more simplified. And that is the fact that out of 2,200 subjects, we had adjudicated with heart failure 1,095, and we know heart failure 1,105. The test was able to rule in 82.9% of the patients with heart failure and rule out 97.9% of the patients with no heart failure. We had 20% of the results, of the patients falling into the gray zone. And out of those, again, the same idea, with 1/3 of them being patients that were adjudicated as having heart failure and 14% with no heart failure. A closer look to this for these subgroups of interest with subjects with renal disease and subjects with obesity. It shows that the assay actually keeps its diagnostic accuracy and ability to differentiate between heart failure and no heart failure in these subgroups as well. This is the second study that we performed, and this used the rule out of 125 in the non-acute setting, rule out that cut point that is recommended by European Society of Cardiology. We enrolled about 700 subjects in cardiology clinics and other outpatient facilities. Patients had clinical suspicion of heart failure, not previously diagnosed, so de novo, and at least one sign, symptom, or risk factors. We had 10 clinical sites across the United States, and for the 125, you see the NPV 99.2%, sensitivity of 91. If you remember the reference interval data that I just showed you, the upper limit that we found was 217 for both female and male. So 125, it's below the upper end of the reference interval, so it should ensure a good performance. However, when you look at the people with comorbidities, you are bound to have some influence from those. So this is why most probably we didn't get 100% here, as one would expect. Now, if you look at the subjects with comorbidities here, the assay has about 0.8 or higher area under curve, so the diagnostic accuracy is still there for these subgroups, even in the non-acute setting. This is just a summary of what I said, and the main idea is that with the use of the age-dependent cutoffs, one can actually improve the specificity. So in clinic, maybe that would allow clinicians to prioritize treatment. For example, patients that are sent for echocardiography that will have higher values are having a higher probability of having heart failure. So also with the use of the gray zone, with the use of the age-dependent cutoffs, you are going to have the gray zone. But even without this gray zone, you are going to have to deal with all these results above the 300, for example, cutoff. So we all have to keep in mind that those are from patients that that might not have heart failure. The mild increases, right, like the gray zone kind of increases, 2/3 of those patients do not have heart failure. And with this, I thank you very much in the name of all my colleagues that worked hard for years on this project, and I am happy to take any questions.
Thank you. Thank you very much, Maria. It has been really interesting for us working every day in the emergency room to know there is room to improve our caveats using NT-proBNP is, of course, of great help. I open the discussion. Alex Mebaza always is the first, right, Christian?
Thank you very, very much, Maria. Now, it's funny because in 2007, I guess we already talked about these 2 points, and I would like to know whether you have ideas on the mechanism of 2 data that we see again and again. One, why NT-proBNP and BNP are increasing with age? And similarly, my next question is why this gray zone? Why those patients are the gray zone? What is the mechanism, the biological mechanism behind it?
Well, with the age, I was actually one, and I will put that here to show it again. So with age, my understanding is that a big part of it is comorbidities, right? So we have to have some clinical conditions identified or non-identified are to be blamed for these increases. And once the myocardial wall stress is there, both of the BNP and NT-proBNP are going to be elevated. Now for the gray zone, what is happening is that you have these conditions, right? So let's forget about heart failure for a second, and let's just think about these additional clinical conditions that can influence peptide. You are not going to have the elevations that you expect with patients with severe, for example, heart failure, right? So you're not having an NT-proBNP in the thousands. You are going to have a milder increase in NT-proBNP due to, let's say, impaired clearance of the natriuretic peptides due to renal dysfunction. So that mild increase will maybe for a patient younger than 50 years old, it might fall right in between 300 and 450. Now, obesity, for example, which actually decreases the natriuretic peptides, will allow a patient with heart failure, right, where you expect increased values to fall either in the gray zone or even below the rule-out cutoff. So these additional conditions are something that we all need to be aware of that can influence diagnosis.
Thank you. Thank you. Other question from the audience? Or, Nick, yes.
Maria, I can't look at you. I'm just going to look straight ahead. Maria, I really enjoyed your presentation. We have a technical question about the assay, because the antibodies that are used in this assay, first of all, are they the same as the antibodies used in previous generation assays that have been used to establish these thresholds or not? And if not, are the age-specific rule-in thresholds performing in the way that you would expect them to? Because I guess I would have hoped that the specificity and positive predictive value would be the same for all 3 age groups, and I wasn't sure that was exactly what the data you showed demonstrated.
Good question. So in terms of the antibodies, this is a new assay, so the antibodies are different. However, the assay is perfectly correlated with the Roche proBNP2 assay. So that's why I was showing you the ICON data, because that is the reason for why we looked at the validated age-dependent cutoffs from Dr. Januzzi's group and said, okay, we are gonna have a good correlation with the Roche assay. Roche assay has this type of performance, therefore we should expect a similar performance, at least with our assay. So if you look at the age groups, now there is a difference, right? So you're referring to specificity and PPV, you said?
Yeah, well, actually looking at it closely now, it's the sensitivity that drops, and that's the rule-in threshold sensitivity, isn't it? Which is less relevant. Actually, it looks pretty good across those three age groups, perhaps slightly different performance in the under 50s. But yeah, that's really helpful.
Yes, the reason for the difference is the way, at least I can explain it, is the presence of comorbidities, and that will differ from, a young person to an old person. So you have this kind of variability between the groups. And of course, depending on what kind of comorbidities we captured within a certain group, we were bound to find differences in performance.
Okay, thank you. Thank you very much, Maria, again. It's been really
Thank you so much. My pleasure, and enjoy
hope
the
to
rest
see
of
you
the
soon
conference.
also in person from the States, and also we can come there.
Me too.
So now I think,
Thank
Christian,
you.
we can leave the podium, and I will leave to Alex and Oscar, the chairman.
Thank you very much. Then you see, this is the trick of my colleagues, is they give me 20 minutes delay and they ask to finish earlier. Oscar, we have a challenge here.
You wanted to present yourself?
No, start.
Okay. Hello, everybody. It's a pleasure to be here. And I think it's an excellent meeting to create a great network. And I think we have the opportunity to know about the novelties about acute heart failure, because of Alex has been one of the assets of the new headlines, of the new guidelines. So Alex is going to present which news comes from these guidelines.
Thank you very much, Oscar. We thought with Christian and Salvatore to show you the guidelines, because I'm sure you saw the guidelines, but there are only, I guess, 200 pages. And it took us hundreds of hours to achieve this. And I thought to show you really what are the important topics. As you see, we were 30-ish, 35 people in the room. What is important to understand is all the recommendations you are going to see when it's written level 1B, 2A, etc. There is a rule in the European Society of Cardiology that we need to have 75% of the people accepting those recommendations. But you should also see it the other way around. If you have only 7 people, which is the 25% who do not accept one recommendation, then we are stuck, and then we need to speak for days and weeks on the recommendation. One of the first things, and really I'm proud, because the task force asked me to work on the definition of heart failure. You would see that for years, and the last 3 or 4 or 5 recommendations, the definition was always heart failure is due to decrease in cardiac output, which is totally wrong. By the way, if you go to Wikipedia, it's still written heart failure is related to decrease in cardiac output. And we know it's wrong, because my group, other groups showed that in heart failure, even in acute heart failure, in the emergency room, cardiac output could be maintained. And in fact, we switched the definition, which is now a structural and functional abnormality with elevated intracardiac pressure. This is really the definition of heart failure, the elevated intracardiac pressure. And indeed, cardiac output could be inadequate, but first increase in heart failure. The other thing that we define, which is very important, is the history, is the natural history of heart failure. And we know today that with many powerful drugs, we can have a patient with a reduced ejection fraction. And many of us, we already seen since many years that if you treat very well your patients, you can have an improvement in ejection fraction. Now, a patient who has a 20-25% of ejection fraction, it could go up to 50%. There are many papers, some of us published by our group and others, showing that you cannot exceed 50%, but many patients can go from reduced to mildly reduced, and this is an improvement in ejection fraction. However, others can go from preserved
have a decrease in ejection fraction and end up by being mildly reduced, then you understand that mildly reduced is coming from two directions. The 2 or 3 important things that we learned from chronic heart failure. One, I would say this is really a very important slide, is the position of natriuretic peptide. For the first time, it's now clearly said that the first line diagnostic tool for heart failure, the first line is natriuretic peptide. Before, if you remember, it was echo, now it's clearly natriuretic peptide. And this is very important. Echo would be, an ejection fraction would be used for stratification, but for diagnosis. And you see that the level is very low, 125 for NT, 35 for BNP. Then many times you may hear in the round or when you are meeting with other physicians, people saying, oh, 70, 100 of picogram of BNP or 700 of NT-proBNP is normal. No, it's not normal. You can see here that the threshold is rather low. The other very important message of the new guidelines are indeed now the drugs that should be given in patients with a low ejection fraction, ACE and ARNI, beta blocker, MRA, and as I told you earlier, we have a big arrival, and this is really so important for our patients, of SGLT2 inhibitors, and loop diuretics was before there, and the treatment can be adapted with the ejection fraction. And then again, in the main algorithms, we also divided the treatment by groups. You see that in the first group, those are the drugs that are saving lives. And I think for the first time, we clearly said, it depends what is your objective. It depends also what the patient would like to have. Is it improvement in quality of life? Is it improvement in survival? Is it both? Patients can have a different objectives. And to improve survival, it's ACE, ARNI, beta blocker, MRA, and SGLT2. And to improve hospitalization and admission, and you can see other objectives. You have other drugs that are also highly needed for our patients. What is very important is here, the class, I would say, I usually say, forget the A and the B for ARNI, but remember that those 5 drugs have a class 1, which is the toppest class, A and B, for most of the drugs. One novelty, if you can just for 1 second pay attention here, you remember this mildly reduced ejection fraction between 40 and 50%. There are several data showing that all the drugs that are working for reduced ejection fraction, all the drugs working for reduced ejection fraction, meaning ACE inhibitor, ARNI, beta blocker, MRA, and SGLT2 inhibitor, they are also all working very well in improving outcome in patients and mildly reduced. Why it is 2B and not 1? Because it's related to post-hoc analysis and there is no trials. Then if you have a patient who has a 45, 46, 47, give him exactly the same therapy as a patient with 25% of ejection fraction, you will improve outcome. For acute heart failure, few novelties. First is the workup in the emergency room and ICU and CCU. You see that here again, natriuretic peptide testing is number 1, together with our clinical exam. There is a nice algorithm starting with patient with congestion, and most often they have a normal blood pressure. Then we would go for loop diuretics. I will let you discover this in the guidelines. In patients with pulmonary edema, here again, usually systolic blood pressure is high. Then we would go for loop diuretics and vasodilators. Right ventricular dysfunction and cardiogenic shock, again, I will let you discover this for a sake of time. And here again, we took former recommendations from expert chain. When the patient is coming, please check first if he needs to go to ICU, cardiogenic shock, respiratory failure, then the patient would go to ICU. If the patient doesn't have a clear immediate emergency, then we need to discover and identify the etiology. And today is CHAMPIT, including coronary hypertension, arrhythmia, mechanical cause, pulmonary embolism, infection, and tamponade. This is one of my last slides that is really a novelty. Some of you may have hearing This presented a few years ago. Now it is in the guidelines. And for the first time, we say, if we give a vasopressor, we check whether we have the right dose by looking on blood pressure. If you give vasopressor and if blood pressure does not go high, you immediately increase the dose. We do the same for vasodilators. And here we said for diuretics, we should do exactly the same. We should check if by giving diuretics, sodium in the urine increases. You see here on the top oral loop diuretics. If the patient at the left side, if the patient has no diuretics at home, you start with 20 to 40 milligram IV. At the right side, if he's on oral dose at home, you give a double dose. And please follow this algorithm because it's so important. After 2 hours, check sodium in your urines. If the diuretic works, it should be higher than 50 to 70, and urine output at 6 hours should be higher than 1 liter, which is 100 to 150 milliliter per hour. If you don't have an increase in natriuresis and an increase in urine output, you should double the dose. And if you gave 40, you can go to 80. This is written at the right side, and check again after 2 hours. This is very important. Then this is the overview. What is clear now, and you see it's green, class 1, oxygen and non-invasive ventilation and diuretics and vasodilators and inotropes are put a little bit behind. And more importantly, maybe when you finish to treat your patient, if he's doing well, if he's in the ward, before leaving the hospital, if he has a low ejection fraction or mildly reduced ejection fraction, you should give him you should start by giving him the oral heart therapies and see those patients again 1 to 2 weeks later. Thank you so much.
Thank you, Alex. Any questions or comments from the audience? So, sorry, you need a good microphone.
Can you ask your question in French, please? Or in Italian, I can handle that as well. Sure. I think BNP in Italian is BNP, no? Okay.
You can come to the atrium and ask. Thank you.
Magari. But be careful, if you approach to this microphone, you will have to give a lecture.
I feel as if my question really doesn't merit me coming up to ask. It's more of a practical question, really. Often in clinic, the difficulty in initiating all of the different classes of drug is low blood pressure. I was wondering, do you think it's better to have a patient on all classes of drug, or to up titrate one drug to the target level that was evaluated in the clinical trials?
It is a several £1,000 question. I try to translate. Usually it's $1, but it's a very difficult question. As you may know, we are running a study named Strong HF, which is patient coming with acute heart failure. And before he leaves the hospital, we give half of the dose of ACE inhibitor or ARNI, half of MRA, half of beta blocker. And we see him after 1 week for safety reason. And then at week 2, we increase to full dose. This is one way. We wait for the study to finish. Milton Packer recently said that we may start with beta blocker and SGLT2. The idea that SGLT2 is safe, and yeah, I think it makes sense that you can give full dose of SGLT2 before leaving, and you give beta blocker. What is written in the guidelines is to start also ACE inhibitor. I would say, knowing because we know that those patients, when they are relieved and they go out of the emergency room or the CCU, the problem is not to do it within days, is really to put the patient on the right track. I would say if you start SGLT2, I think we all agree that this is safe. And then I would start either half beta blocker or half ACE, I will wait 2 weeks and then I would give the third drug. MRA is also safe if the patient is not has no kidney failure. Then SGLT2 and half MRA, I would give it immediately, and then beta blocker or ACE, depending on the patient, either at discharge or maybe 2 weeks to 1 month later. Are you okay with that?
Yeah, thank you.
Thank you.
Alex, any kind of counseling in the guidelines? When is the proper moment to discharge a patient, either in the emergency department because the decompensation is not too severe to be admitted, or after hospitalization, when is the best moment? Because one of the main problems is the vulnerable period that happens just some weeks after the hospitalization, and patient experiences a lot of bad outcomes. Any kind of guidance?
No, unfortunately, there were nothing. And I think really, and I'm talking to you, Nick, Christian, and all the people who are in committees and association of the ESC, there is really a room to do it really very, very quickly, because in fact, in the guidelines this year, we had so many novel medications and chronic heart failure. As you saw, chronic heart failure was really expanded compared to acute heart failure. Then really there is a room for discharge from the emergency room, from transition emergency room ward, transition emergency room ICU, and even when the patient should be discharged from the ward. And then clearly there is a paper that we should write, because there are many, many questions and people are wondering what we should do.
Any more questions? You have a mic? Okay. Yeah, of course. Let's try.
Any better? No.
Come.
Hello. Hi. Thank you for the talk. It was very good. I liked the table.
You know what we can do? Can you just introduce yourself?
Yeah.
That could be nice.
My name is Ryan Wereski. I'm one of the research fellows from Edinburgh, working with Professor Mills. Yes, I really like the table that you had split the drugs into drugs that improve mortality and drugs that improve symptoms. I think that's really good for patients. The really question I had was, do you preferentially start an ARNI over an ACE inhibitor, or would you suggest an ACE first, and then if the patient's stable, switch them to ARNI?
I think this is one of the topic that took 18 months to achieve, and you saw that ARNI was 1B. It was 1B just because we couldn't have the 75%. I think we always fell short at 70% or 71% of approval. Why? Because there is a rule in the ESC saying that if there is not two large phase 3 trials, you cannot put a 1A. And then people often ask me, but how come SGLT2 had 1A? In fact, because it's two drugs from the same class, but two different drugs, which each had a pivotal trial. Then, in fact, SGLT2 inhibitor benefit from two trials from two different companies, but getting the same results. And ARNI had only one trial. It's as easy, as simple as that. It's nothing, no rocket science behind that. Now, saying that, the large majority of the people on the task force agreed that if you put ARNI as a first class of drug, you see some patients having a huge diuresis improving. However, we felt that also in some countries, ARNI, it's expensive. It's not used frequently, and that ACE inhibitor is doing also the job. But again, the B should have been maybe a 1A. Then I would say it depends on what you are doing in your center, in your country, or the national guidelines. But for France, for example, I can tell you ARNI is now used as in the first line in many centers. And again, SGLT2 is coming very, very hard and be used in so many patients, because kidney dysfunction is also improved. And this is for us incredible.
Thank you.
More comments? Okay. Okay, so thank you, Alex. I think we can move to the next speaker. You need the glasses?
Yeah, I think you have French.
Okay, so next speaker is Antoine Quimon with the presentation ECMO hypothermia in cardiogenic shock in patients under ECM. Thank you, Antoine.
Thank you. Thank you for the invitation. So my talk, my PowerPoint. It will be a bit more difficult without.
Then for the next presentation, while the slides are coming, it's 7 minutes presentation and 3 minutes discussion. And all those presentations are part of the award. Then I see all the jury is already. Where is the president? She's still here, yeah. Okay. Be careful. And just an advice: don't hesitate if you have a little bit of chocolate or something to go to say hello to the president.
Okay.
It's sometimes help. Do you agree, our president, that it may help? Wine, oh, mamma mia. We have a problem with the slides. Should we move to another? Tu les avais mis là-bas?
Oui. J'ai envoyé ma présentation.
We have 3 presentations before the next session, and this is a session cardiogenic shock and heart failure. Constantina is ready as well for the next. Yes, okay. Do we have the slides of Constantina by chance? Is it easier? Or can Constantina give the lecture of Antoine Kimoun with his slide? No. Do you have the slides of Constantina? Can we start with Constantina, maybe? Yeah, apparently he did. Indeed, all the fellows, they are advised to go to put their slides. And by the way, while we are talking also about this, for the Wi-Fi passcode, if you don't have it, it's the name of the hotel, high V, high H, big H, small I, small V, small E, 2018. Big H, I, V, E, and small, 2018. Okay, do we have Feriel or Constantina lecture to start? Apparently, it's not necessarily easy. Alors, where are we? And the winner is? The winner is Antoine.
You have 5 minutes, Antoine.
Antoine.
Sorry.
Antoine, then don't forget, 3 minutes presentation, 7-minute discussion.
So that will be a big challenge. So thank you for the invitation. I present you the HypoECMO trial assessing the effect of hypothermia on mortality on cardiogenic shock patient rescued by VA ECMO. So my conflict of interest. To begin, a bit of pathophysiology. This is a classical figure of the old and new paradigm in cardiogenic shock. The old paradigm is explained by the mechanical cardiac dysfunction centered on the low cardiac output and the congestion leading to ischemia and increase in cardiac dysfunction. With the new paradigm, there is a central place for inflammation with a massive release of NO and cytokines leading to vasoplegia and a decrease in cardiac contractility. In fact, cardiogenic shock is not only a mechanical cardiac disease, but also an inflammatory disease, a bit like septic shock. I'm an intensivist. So this is a new definition of cardiogenic shock, stratified with 5 stages from A to E. A, at risk; B, beginning, the baby cardiogenic shock; C, classical cardiogenic shock, deteriorating or refractory cardiogenic shock; and E, extremis, most often refractory cardiac arrests. And in line with this stratification, you have an increase in the inflammation. On from stage C, you have organ failure, mainly kidney and liver failure, which are prognostic in cardiogenic shock rescued by VA ECMO. So of utmost importance, you have to initiate ECMO before the onset of this new organ failure, kidney and liver, from stage C sometimes, but most often when you have a refractory cardiogenic shock or in case of refractory cardiac arrest. Our group tested hypothermia in refractory cardiogenic shock under ECMO in an experimental pig model of STEMI cardiogenic shock in refractory state, rescued by VA ECMO, recreates the cardiogenic shock by ligation of the left ascendant artery. Animals were randomized in the hypothermia group or the normothermia group, 12 animals only. On the, we maintained the experimentation for 8 hours. The main results were that the total amount of vasopressor infused were lower in the hypothermia group compared to the normothermia group, and that the vascular responsiveness to vasopressor was increased in the hypothermia group compared to the normothermia group. Thus, our hypothesis was that early moderate hypothermia compared to strict normothermia may improve mortality in patients with cardiogenic shock receiving VA ECMO. ECMO was a multi-center randomized control trial with 20 centers in France only. Inclusion criteria were very simple: intubated cardiogenic shock treated with ECMO, and non-inclusion criteria were refractory cardiac arrest. They were too severe. ECMO for LVAD or heart transplantation and uncontrolled bleeding. The coordinator was Bruno Levy, Bruno Levy. The study design, patients have to be included within the 6 hours after ECMO initiation, and the temperature was managed by the heat exchanger in the device during 24 hours with a progressive reheating period for 48 hours. But it is important to remember that in the normothermia group, the temperature was also controlled by the heat exchanger, so no fever. Endpoints, for the primary endpoints, it was 30 days mortality, and just remember these secondary endpoints: composite endpoint of death, cardiac graft, stroke, or escalation to LVAD at day 30. The sample size was a bit optimistic, maybe, because the anticipated mortality in the control group was 50% and 35% in the intervention group, with a relative risk reduction of 30%. So the anticipated sample size was 334 patients. The flowchart was very classical. Just a look that 124 patients were non-intubated and thus non-included. It's a very huge part of patients under VA ECMO. Temperature curves fitted well, with a huge difference between the two groups, with no overlap between hypothermia group and normothermia group. And characteristics at inclusion were very classic for a refractory cardiogenic shock population, mainly male, with prior to inclusion a cardiac arrest in 48%, and the first etiology was obviously acute coronary syndrome, and more than 80% of the population received vasopressors. This is a primary endpoint, a bit disappointing because the result is neutral, with no difference between the two groups but 42% rate of mortality in the hypothermia group compared to 52% in the normothermia group. This is a secondary endpoints, interesting because at D13, disease, cardiac graft, LVAD on stroke were slightly lower in the hypothermia group compared to the normothermia group. And this is important, there is no safety issue except for the number of transfusion a bit superior in the hypothermia group. In conclusion, early application of moderate hypothermia for 24 hours does not increase survival compared with strict normothermia. But regarding the curves, the composite endpoints at 30 days was lower in the hypothermia group, but it is only a secondary outcome and there is no safety issue. Thank you very much for your attention.
Thank you, Antoine. A nice presentation. Just a question, because you have said that it's 10 hospitals in France involved?
20.
20. Yeah. How long it took to recruit 300 patients on ECMO?
Extremely fast.
Extremely fast.
Extremely fast.
Wow.
Only two years and a half only.
Okay, you are using a lot of ECMO, I see.
And we cannot say where, but the paper is submitted in a big journal.
For a long time.
It's good. Okay, Salvatore.
Congratulations, really good job. Just one question. I know that was not the primary endpoint of the study, but as you know, we delivered an important score for cardiogenic shock into the great network. That was from Veli-Pekka Ariola. Did you have any data is it a great opportunity to check the value of our score in these patients to see which patients is going to be treated or not? This is something that is having this big population is really an opportunity. I don't know if you had already the idea to do or you are going to do it.
No, it is not planned, but yes, I know very well the CardShock database. I don't know the patient who will benefit the best of the hypothermia. Maybe those with renal, just the beginning of the renal and the liver dysfunction. That's our hypothesis, but this is not sure. There is no difference between the different subgroups because we included a very large population. I mean, it went fast, okay, but we included acute myocardial infarction, chronic dilated cardiomyopathy, myocarditis, and so on. So yes, it maybe they are not exactly they are not exactly the same disease. So yes, we have to do this work, but it will be a next level. Many questions.
Frank, in Italian.
Okay, in Italian. See. So nice job and a good sized paper. Usually when you have a negative outcome, there's a power associated with it. And I expect since you put this to a fancy journal, you know the power. What was the power?
As the power of the study?
Yeah.
80.
80, okay.
80%, but yes, 30 relative risk reduction. It was a bit optimistic, obviously, but we calculated with that with only 50 to 70 other patients included, it would have been significant, but that's the game.
Yeah, because they fell short at the end. I mean, 0.07, it was okay. Okay, we need now to move on. Thank you so much. Thank you. And again, it's nice and the great network to have presentations from so high level. Now we have another presentation from high level, Constantina Antai, case with acute heart failure. Thank you, Constantina.
Good afternoon. Thank you so much for the kind invitation. You have all the regards from Professor Parisis. I will be presenting a case of acute heart failure. It is about a 76-year-old male presenting at the ED, complaining of dyspnea and fatigue since 3 days before. He was obese and a former smoker. He had a history of COPD, 50 packet years. He had a poor functional capacity and he was receiving metoprolol 50 milligram twice a day. The blood pressure was kind of low, systolic 86 and the diastolic 52. His heart rate was 50 beats per minute. His respiratory rate 28 per minute, and the saturation was 89 in room air. From the clinical examination, he had jugular vein distension, peripheral edema, and diminished breath sounds, and he was wet and cold. The ECG showed the atrial fibrillation with slow ventricular rate. So our patient had at least 3 clinical signs of acute heart failure, hypoxemia, signs of systemic congestion, and signs of low cardiac output state. So we decided to have a quick echocardiogram in order to assess the function of the 2 ventricles. And it seems that the right ventricle was dilated and with a mildly impaired systolic function. He had a moderate at least tricuspid regurgitation. And we can see the typical D shape of the left ventricle, suggestive of pulmonary hypertension. And from the abdomen echo, we have ascites. So we have a patient with acute right ventricle failure. And what should we do next? It seems that the first step is to assess the severity and hemodynamic and provide hemodynamic and respiratory monitoring and support to the patient. And this means by clinical evaluation, the blood pressure, diuresis, and the mental status, biochemical evaluation, lactate liver markers, renal function, the BNP and the troponin, some imaging, echocardiography, and sometimes a CT scan in order to exclude the acute pulmonary embolism, for example, or even invasive evaluation, something that is very difficult in the emergency department. And of course, we must, according to the current guidelines, we should provide oxygen to a patient with hypoxemia, a saturation below 90% or a partial oxygen pressure below 60. And if this doesn't work and the patient is very in great distress, we should apply non-invasive positive pressure ventilation, but with caution in patients with right ventricular failure, because we will increase the afterload and this could be detrimental for our patient. This is the biochemical evaluation of our patient. So he had markers of acute right ventricular failure, like increased lactate levels with very high values, 70,000, and elevated NT-proBNP. No, it's okay. The lactate level was 2.8, and the NT-proBNP was 70,000 picograms per ml. And he had also elevated values of troponin. He had normal liver values, but abnormal renal function, and the D-dimers were normal. So the next step was to identify and treat causes and triggering factors. According to the current guidelines, you will have to exclude these conditions, known as CHAMPIT. And we have to keep in mind all these different diagnoses. And as our patient had the negative D-dimers and he had no signs of ischemia on the ECG, but had signs of chronic pulmonary hypertension from the echo, we suppose he was an acute decompensation of chronic pulmonary hypertension. So the next step was to optimize the fluid status. If the patient has a volume overload, one should give diuretics, furosemide at first, and then double the dose if this is not enough, or use combined diuretic therapies like metolazone. And if this is still not enough, you can provide the patient with renal replacement therapy. But if the patient is dehydrated and he has a low CVP, cautious fluid, we should give fluids cautiously. So we gave our patients furosemide 40 and then another 40 milligram of intravenous bolus. But our patient had also low blood pressure, so we had to maintain the arterial pressure and to increase the pressure and the vital organ perfusion. And according to the guidelines, we could give a vasopressor, preferably norepinephrine. Except for epinephrine, norepinephrine, one should think about giving inotropes in order to reduce the cardiac filling pressures like levosimendan, dobutamine, or milrinone. And this will improve peripheral perfusion and maintain end organ function as well. We gave our patient norepinephrine and dobutamine. So in conclusion, as a take-home figure, when we manage patients with acute right ventricular failure, we should first exclude acute coronary syndrome with nerve involvement and an acute pulmonary embolism. Then if this is not the case, we should optimize the fluid status. And if there is peripheral hypoperfusion and hypotension, we should think about giving vasopressors in combination with inotropes. And if all of these measures are not enough, we should consider about providing mechanical circulatory support or renal replacement therapy, or even in sometimes palliative care. Thank you very much.
Thank you very much. Konstantina, questions? Yes, right ventricle. Not so frequent, but you need to be really expert to manage those patients. Yes.
Thank you very much for your presentation. I was just wondering about the 3 inotropes that you listed, like milrinone, dobutamine, and levosimendan. And your patient got dobutamine. Like, is that the standard of care in your clinic? Because we always have the same discussion with these patients, like which inotrope to give. And some say like levosimendan has the best data for like the right ventricle, and like, maybe you can comment on that.
Yes, it seems that we gave the worst choice for the patient. I think levosimendan and milrinone is much better for the right ventricle, but it is they are more difficult to give it in the emergency department. So we gave what was possible in the emergency department, and then the patient was transferred to the coronary unit.
Yeah, again, to make sure that we are all on the same line, what we wrote on the recommendation just before the ESC guidelines is there are 2 things to do when there is a right ventricular dysfunction with hypotension. Try to not give too much fluid, a little bit, but not too much unless you have congestion, and you quickly give vasopressor. And we said inotrope are only in few patients where you have clearly an evidence of low cardiac output. And then, as you said, we can choose whatever. But first is minimum of volume and vasopressor to improve coronary perfusion and other perfusion. Other questions? No? Konstantina, thank you so much. Thank you very much.
So last but not least, presentation, Feriel Azivani from France is going to present DPP3 in cardio-oncology.
Thank you. Does it work? Yes. So hi, everyone. So I'm really delighted to be here today to present our preliminary results on dipeptidyl peptidase 3, DPP3, in the field of cardio-oncology. Okay. Chemotherapy-induced cardiac dysfunction is one of the most important side effects of chemotherapy
treatment in cancer patients. It is associated with increased morbidity and mortality. It can happen early or late, even years after completion of chemotherapy, and it obviously limits optimal anti-cancer treatment. But cardiac dysfunction in cancer patients can also be caused by cancer itself. Some experimental and some clinical studies show that cancer or tumors can induce decreased protein and heart mass, disrupted myocardial structure, increased inflammation and fibrosis, leading to, so it doesn't work, okay. Leading to a decrease in cardiac function. The hypothesis behind this phenomenon is based on molecules such as cytokines that are secreted by the tumor and that will cause the cardiac cachexia, inducing cardiac dysfunction. Now moving to DPP3. DPP3 is a metallopeptidase, zinc dependent. It's known in vivo substrates are angiotensin 2, 3, and 4, enkephalins and endomorphins. DPP3 is mainly cytosolic, where it plays a role in inhibiting oxidative stress, but it can also be present in the circulation of healthy and sick individuals. Our team showed the prognostic value of DPP3 as a biomarker in predicting mortality in septic shock and cardiogenic shock patients. At the experimental level, Benjamin Denio showed that the injection of DPP3 into healthy animals will decrease the cardiac function. On the other side, the inhibition of DPP3 by using an inactivating antibody, the protizumab PCZ, will improve the cardiac dysfunction in 2 models of acute heart failure and septic shock. More importantly than now, is that DPP3 is highly expressed by tumors and cancer cells. And some studies show that DPP3 activity is associated with the histological grade of the tumors. Very recently, Tong and his colleagues show that silencing DPP3 in cancer cells before injections into healthy animals will reduce the tumor size and volume. On our side, what we've seen is that DPP3 protein and mRNA expression is overexpressed after doxorubicin treatment in the heart of mice or in vitro in cardiomyocytes. Our hypothesis is then that DPP3, which can be expressed by cardiomyocytes and or cancer cells, is implicated in cardiotoxicity induced by cancer and or chemotherapy. Big challenge. So we use 2 approaches, an in vitro one using cultured cardiomyocytes, ovarian cancer cells, and conditioned media, and another approach, which is an in vivo approach, using developing an very acute and severe model of cardio-oncology induced by doxorubicin in wild-type mice and DPP3 knockout mice. Our results showed in vitro that DPP3 protein expression is overexpressed, is induced, in cardiomyocytes and ID8 cancer cells when treated with doxorubicin. And this was associated with a higher mortality after those treatments in those cell lines. When now we treated those cell lines with DPP3 with 2 doses of DPP3, a lower one and the higher one. Just for note, the higher one will look like what we find in the normal healthy individuals. We didn't see any effect in survival of cardiomyocytes, but we observed that DPP3 tends to promote the survival of cancer cells. Moving now to the PCZ. So we first treated the cardiomyocytes. So on the left, we treated first the cardiomyocytes with PCZ and doxorubicin. And what we've seen is that PCZ slightly, very partially, but significantly prevented the mortality, decreased the mortality induced by doxorubicin. Then moving to the conditioned media experiment, when we incubated the cardiomyocyte with the secretum of cancer cells not treated, we didn't observe anything, any effect on the survival of the cardiomyocytes. But when we stressed those cells with doxorubicin, we observed that this secretum can induce mortality of cardiomyocytes. Then what we did, we took the last experiment, so the secretum of cancer cells treated with doxorubicin, and we pre-incubated it with PCZ for 30 minutes before putting it on cardiomyocytes. And what we observed is that PCZ prevented the mortality induced by the secretum of cancer cells treated by doxorubicin. At the in vivo level, what we observed is that the knockout mice, DPP3 knockout mice, presented with a more acute and severe heart failure just after the completion of the treatment. But those mice seem to recover their cardiac function, to recover their weight. And this was associated with less mortality than the one observed in wild-type mice. At the time of the sacrifice, which was 2 weeks after the termination of the treatment, which is obviously too late, we didn't observe significant differences in some markers of oxidative stress. To conclude, definitely DPP3 is implicated in doxorubicin-induced cardiotoxicity, but we need to consolidate. We need to do more and more experiments to understand the dual role of DPP3, which is probably linked to its intracellular and beneficial antioxidant effects versus its circulating inotropic negative role. Yes. I would like to thank my team, and especially Noma and Adrien, who performed mainly all the experiments. And thank you for your attention, and I'm happy to get questions.
Thanks, Ferial. Any question in the room? Any comment? Do you see any kind of possibility of target DPP3 in the next years to avoid chemo-related cardiotoxicity?
Maybe I think that what we are missing right now is the circulating DPP3 in those patients. We have really few data on circulating DPP3 in cancer patients, and it seems to be high. We still don't know if it is prognostic of anything of survival or of cardiotoxicity, which would be the best outcome. But yeah, I think it's too early.
Okay. More comments? No? Thank you.
You're
Thank you,
welcome.
Ferial.
I guess now it's time for Nick and Christian to take over.
Bravo, guys. Bravo. Very good.
Okay, super. So hopefully that's the microphones all working. It would be lovely to have lots of questions from the audience for this next session, which I'm sure will generate some controversy and discussion. Novelties in the diagnosis of myocardial infarction. Christian and I will talk you through what looks like a Scottish-Swedish collaboration over the next hour, and then it's coffee. So I promise we'll finish on time.
We'll try Swiss time.
We'll try it. Swiss time. You can do the timekeeping. How about that? So first up is Pedro. I don't know where Pedro is. There he is. Now, Pedro, if you like his talk, learned everything he knows from the cath labs at the Royal Infirmary of Edinburgh. If you don't like it so much, he's also been doing some work with Christian in Switzerland recently, which he's going to present to you just now. Novel criteria for the observed zone. Pedro, lovely to see you.
Thank you. Oh, so thank you very much, Professor Mills, for the kind introduction. So, dear Professor Nickel, dear Professor Mills, dear colleagues and friends, my name is Pedro Lopez Ayala. I'm a clinical research fellow at the Cardiovascular Research Institute Basel, and it's my great pleasure to be here today in this wonderful city and to have a face-to-face meeting. So I would really like to thank the organizers for making it possible and for the hard work for it. So in the next 7 minutes, I will present our common work entitled Novel Criteria for the Observed Zone of the ESD01 hour high sensitivity cardiac troponin T algorithm. So before starting, just one quick question. How many of you or of your institutions are using the ESD01 hour algorithm or are planning to do so? So please raise your hands in case. Okay, perfect. So I hope that the following presentation will help to clarify some concerns regarding the observed zone. So the ESD01 hour algorithm has a class 1 recommendation in the latest ESD NSTEMI guidelines. It has shown a very high safety for early rule-out, a high accuracy for ruling of NSTEMI, and a definite triage in about 70 to 75% of patients. But what about those patients being triaged to the observed zone? Well, the latest ESD NSTEMI guidelines recommend a 3-hour high sensitivity cardiac troponin determination in these patients. However, no specific cutoff for further triage is recommended. Now, recently in 2018, a 0.3-hour troponin T absolute change of 7 nanograms per liter was proposed. And last year, we showed the performance of this cutoff, which showed a very low safety for rule-out of NSTEMI. Nick Mills was also chairperson, so probably he will remember. So therefore, our aim was to derive and validate a novel 3-hour pathway for the observed zone of the ESD01 hour high sensitivity cardiac troponin T algorithm. So for this endeavor, we used the APACE cohort. APACE is a multi-center international diagnostic study in which adult patients presenting to the emergency department with chest pain are recruited. Serial blood sampling is obtained, and final diagnostic adjudication is performed by 2 independent cardiologists using the 4th universal definition of myocardial infarction and using all medical records, cardiac imaging, troponin values, and 90 days follow-up. Safety was assessed as the sensitivity and negative predictive value of ruling out index NSTEMI, while accuracy as the specificity and positive predictive value of ruling in index NSTEMI. For externally validating our novel criteria for the observed zone, we used the TRAPID-AMI cohort, which is an independent prospective international multi-center study, which recruited patients in 12 centers on 3 continents. So very briefly, regarding the derivation and internal validation of this algorithm, of this novel criteria, we used a bootstrap validation approach. And very briefly, we developed the algorithm using the entire original sample, so the sample of APACE, using all patients. For developing the algorithm, we predefined performance targets of 99% for above 99% for sensitivity and negative predictive value. We tested multiple troponin T cutoffs. We selected an optimal combination, and we determined the apparent performance. Now, for the internal validation, we used a bootstrap technique, which is a resampling technique, and we generated a bootstrap sample by sampling individuals with replacement from the original sample. We developed the algorithm in the bootstrap sample, applying the same developing methods as in step 1, so step A, B, and C. Then we determine the apparent performance of this bootstrap algorithm in the bootstrap sample, as well as in the original sample. And then, in order to calculate the optimism, the difference between the bootstrap performance and the original performance was obtained. This was repeated 1,000 times. An average optimism was obtained, And we subtracted this optimism from the apparent performance obtained in step 1 to obtain an optimism corrected estimate performance, so to say the internal validation. So going on to the results, a total of 2,076 patients had 0, 1, and 3 hour troponin T values. The application of the EST01 hour algorithm showed a very high safety for rule out and a high accuracy for rule in, and a total of 27% of patients remained in the observed zone. The optimal combination of a 3 hour single value and a 0.3 hour absolute change was a 3 hour value less than 15 nanograms per liter and a 0.3 hour absolute change less than 4 nanograms per liter, allowing a very high safety for rule out, and sensitivity and negative predictive value were above 99%, and only 1 patient was missed. For rule in, a 0.3 hour absolute change above or equal than 6 nanograms per liter allowed a very high accuracy with a positive predictive value above 85%. The bootstrap internal validation showed very similar findings to the apparent performance, both for rule out and for rule in, and a total of 62 patients, when applying this novel criteria on top of the EST01 hour algorithm, were ruled out. 21% of patients ruled in, and importantly, there was a 35% relative reduction in the observed zone, and even more important, a 50% relative reduction in end-STEMIs in the observed zone. External validation in the TRAPID-AMI cohort showed very similar findings, both for the EST01 hour algorithm, as well as for the novel criteria for the observed zone. Again, we achieved a 40% relative reduction in the observed zone and a 50% relative reduction in end-STEMIs. So as any other study, this study merits some limitations. We conducted it in needy patients, therefore we cannot comment on the performance in other clinical settings. We cannot generalize our findings to patients with terminal kidney failure requiring dialysis, as these patients were not included, as well as late presenters defined as a chest pain onset and maximum above 12 hours. So dear chairpersons, dear colleagues and friends, to summarize, a novel derived pathway combining a 3 hour high sensitivity cardiac troponin T concentration less than 15 nanograms per liter and a 0.3 hour absolute change less than 4 nanograms per liter allowed a very safe rule out of end-STEMI in patients remaining in the observation of the EST01 hour algorithm. Full study results are now available in circulation, and thank you very much for your attention, and I will be happy to receive any questions.
Super presentation. Any questions from the floor while you're thinking? Pedro, congratulations on a really important, I think, addition to the work that your group's done on this pathway. It always felt like a little missing question, what to do in the observed zone. I guess the question I have is what went wrong with the prior attempt? I mean, you started this process by looking at an algorithm that had been developed in another institution, and your findings were quite striking. So can you just comment on what went wrong with the prior attempts to do this, and why you think your approach was better?
Thank you very much for your question. If I needed to summarize it in 2 words, I would say sample size. So the study of 2018 that I mentioned in the background in the introduction, they had a total of, or let's say, if I remember correctly, 120 patients in the observed zone, and the number of end-STEMIs in total was 11, which is a 2%. So with 11 STEMIs, it's difficult, and obviously. You can maybe reach 7 nanograms per liter for rule out because maybe these patients, the 0.3 hour absolute change was 8, 10, 20 with only 11 patients. That's one main thing. Also, they just shown apparent performance, which also has overfitting, no internal validation, and also the troponin that they used for the final adjudication. It was a conventional troponin T. SA, it was not a high sensitivity troponin T, and therefore probably missing some myocardial infarctions.
Very diplomatic response. If I'm allowed one last question. So what do we do after following your algorithm if they still end up without a decision at 3 hours. What's your approach in clinical practice to these patients? How do you decide what to do next?
I mean, probably we also need to know the limitation of troponin. And probably in these patients, serial sampling at 6 or 12 hours is probably not the, I mean, it's possible obviously, but we also need to take into account imaging, non-invasive imaging. And if I'm not wrong, your group just published a paper in Circulation, if I remember, or in JAC, sorry, using troponin to guide if CT angiography is needed or not. So probably CT angiography in these patients is an interesting option.
Super, thanks. Okay, we will try and keep on schedule. So.
Yeah. For the sake of time, we're going to switch to the next speaker. Apologies for my Scottish. I hope I get this right. Matthew Lowry. Pretty good. Okay. Matthew is going to speak about age and the diagnosis of acute myocardial infarction. We're all geriatricians was the title of a beautiful article, editorial. So I'm very curious what you have to say.
Yeah, well.
Can the audience hear?
Apologies, that should be better. But thanks very much for the introduction. So my name's Matthew Lowry, I'm a clinical fellow at the University of Edinburgh, and I'm going to talk about the influence of age in the diagnosis of acute myocardial infarction. Is it possible to have the slides up, please? Okay. So the 99th percentile is used as the diagnostic threshold for myocardial infarction, and it's derived in a cohort of healthy individuals. However, the age of this cohort can influence the 99th percentile, and we frequently observe older patients without myocardial infarction have a troponin level above this reference value. Using a reference value derived in a younger patient population may therefore incorrectly diagnose myocardial infarction in older patients, resulting in inappropriate treatment and potential harm. So our aims were to assess the performance of cardiac troponin to identify type 1 myocardial infarction in older patients using the 99th percentile, compare this against performance when using age-adjusted thresholds and universal thresholds above the 99th percentile, as both of these have been proposed as means of improving specificity of troponin testing. And then finally, to assess what impact cardiovascular comorbidities may have on this performance. To do this, we conducted a secondary analysis of the high sensitivity of troponin in the evaluation of patients with suspected acute coronary syndrome randomized controlled trial. And I think the important thing to know about this trial is that it had a consecutive recruitment of patients with suspected acute coronary syndrome, meaning a large and representative patient group was recruited. And all cases of myocardial injury were adjudicated according to the fourth universal definition of myocardial infarction, allowing us to use our desired endpoint of type 1 myocardial infarction. The trial used an Abbott Arctic Stats high sensitive cardiac troponin I assay, and you can see the age-adjusted and universal thresholds in the graph. The age-adjusted thresholds were derived in a general population study, including about 19,501 patients, and the universal threshold was taken from the ESC guidelines. The two outcomes of interest we're looking for were the diagnostic performance of presentation troponin, which we're going to measure using sensitivity, specificity, and positive predictive value calculated using a confusion matrix with bootstrapping, and to assess cardiovascular comorbidities, we used logistic regression. So this is a table showing the patient demographics in the trial. For this subgroup analysis or secondary analysis, we included 46,444 patients who age range from 18 to 108. If we focus on the older group of patients, those who are 75 years or older, we can see that compared to younger patients, they're predominantly female. They're less likely to present with chest pain. As expected, cardiovascular comorbidities are more common. Also less likely to have a ischemia on a 12-lead ECG. And we can see that's the percentage of any form of myocardial injury, and particularly type 1 myocardial infarction, is increased with age. This graph shows the distribution of patients in the study. And those patients who have at least one troponin above the 99th centile are colored in blue. And I think what's most striking about this is you can see the majority of patients who were suspected of acute coronary syndrome had negative troponin measurements. But I also hope you can appreciate that the proportion of those with myocardial injury also increases with age, to the point that patients who are 90 years or over, more than 50% of them had some form of myocardial injury. This graph below shows the adjudicated diagnosis according to the 4th universal definition as a proportion of those patients with myocardial injury. And here you can see that type 1 myocardial infarction, which is in red, as a proportion of the cause of, or of any cause of myocardial injury, actually decreases with increasing age as other forms of myocardial injury, acute myocardial injury, type 2 myocardial infarction increase. Looking at the specificity across age, this is a line of best fits graph, and you can see that the 99th centile is represented in red, age-adjusted thresholds in the orange dashed line, and the uniform rule-in threshold in blue. And we can see that overall specificity decreases with increasing age, with the universal threshold achieving the high specificity across the 3 thresholds listed. If we look at the positive predictive value, we can see this rise and fall, which is very similar to the proportional bar charts that we viewed in the previous slide. Here we can also see that the positive predictive value decreases with increasing age. Again, the universal threshold performs best amongst these 3 thresholds, but it's still important to recognize that patients who are 75 years old, the positive predictive value is still less than 50% for all of them. Looking at the sensitivity, this was not changed across age groups, but was more in line with the degree of increase in each threshold above the 99th centile, as we'd expect. This table shows the output of the logistic regression modeling. I think it's best just to focus on this top line. So the 2 models, the baseline model had as its dependent cardiac troponin above the 99th centile, and its explanatory variable as any troponin above the 659th centile. Sorry, the dependent was some type of myocardial infarction. And the comorbidity adjusted model added in the comorbidities that you can see on the left. And although we can see that the odds ratio decreases as we go across age groups, there's no difference in the odds between the 2 models. And we conclude that the comorbidities that were included in this model didn't change the association of a raised cardiac troponin type 1 myocardial infarction. So in conclusion, age has a significant impact on the rule-in of type 1 myocardial infarction. The universal threshold performed best. However, there was at the cost of reduced sensitivity. And in our cohort, 1 in 2 patients who are 75 years or over with a presentation cardiac troponin above the threshold ultimately did not have a diagnosis of type 1 myocardial infarction. And my takeaway message would really be that in older patients, clinicians should consider carefully the rule-in of type 1 myocardial infarction on the basis of a presentation cardiac troponin sample only. So thank you very much for your attention. I'd like to welcome any questions.
Thanks, Matthew. Very important work. Are there questions from the audience, Salvatore?
Can you hear me? Yeah.
Yes.
Congratulations, Matthew. A really great job. I'm wondering which is really the value of each, comorbidities, because you put there cardiovascular disease. I think that atrial fibrillation should be considered as one of the top of criteria, because like we saw on the presentation on NT-proBNP, able to detect outside heart failure, some other comorbidities. Why not to use in these patients the use that I really like very much, the concept that we are going to take careful decision-making in these elderly patients age greater than 75. How much is the role of each one? Which is how much atrial fibrillation that I was not looked at that you have in your patients?
Yeah, thanks very much for your question. I think you're absolutely right. There's lots of comorbidities that weren't included that will be important and affect the performance of these investigations. And I guess I'd also like to start by saying we are limited to some degree in the data that we're using in this study. The comorbidity data was collected using an electronic health records. We didn't have an objective measure of much of these comorbidities, for example, BNPs like biomarkers or echocardiography. And we also know that as well as cardiovascular comorbidities, there are non-cardiovascular comorbidities that can result in elevated troponin samples, such as chronic obstructive pulmonary disease. So I think the role of comorbidities is not quite fully answered there. And I think that really a more extensive study that we have these more objective markers of disease severity would be required to do that.
So one possible suggestion for you as a next step on, I mean, to provide really, I mean, the help for clinicians. I mean, the cutoffs that you have tested, most of them were derived for the ruling of myocardial infarction, kind of all types, including type 1 and type 2. And so I think it would help to see whether in your cohort, if you combine type 1 and type 2, you get to similar positive predictive value than the previous work. And if that's the case, then I think the lesson would be the cutoffs work, but particularly in elderly patients, if you have a clear trigger for type 2, like if you have atrial fibrillation with a rapid ventricular response, then of course your message would be, of course, do not bring the patient to the cath lab, but consider type 2 as possibly the main mechanism, acknowledging that, of course, many of these patients then have limited workup to be very sure whether it's type 1 or type 2, but that is just a suggestion of how to make additional use of this fantastic data set that you have.
Yeah, thanks very much. In subgroup analysis, we did recalculate the parameters with a combined endpoint of type 1 and type 2 myocardial infarction. And we can see that it results in an overall improvement of specificity and positive predictive value compared to just using type 1. But we still see the decline in these parameters with increasing age.
Well, I have the urge to ask one question too. What about how are we going to improve the diagnosis of myocardial infarction in older patients who don't present with typical chest pain?
Yeah, I think that's very, very difficult. I guess that that kind of falls partly down onto your clinical acumen. I think one thing I would also say is that I think it's better to think about troponin not as a kind of binary decision-making tool, maybe perhaps as it is widely used, and to think about it more as a piece of the puzzle or adding to the probability of what the diagnosis might be and whether that could be type 1 myocardial infarction. So I think it's really about considering the whole picture of the patient, and as opposed to saying, if this is positive, this is ruled in, just thinking about, well, what's the probability of that?
Thank you very much.
Thanks, Matthew. Okay, so Bernard Okamura. Bernard ready? Perfect. So that was a thoughtful and thought-provoking presentation on thresholds. Always a challenge in diagnosis of myocardial infarction. We're given the 99th centile as a working threshold from the universal definition that requires some clinical acumen. Okay, brilliant. Bernard, welcome. Hopefully your slides will be following shortly. So we're moving away from thresholds and onto neutrophil lymphocyte ratios.
Good afternoon, everyone. Dear Professor Mills, dear Professor Nichols, dear audience. It is my pleasure to present to you our findings on the neutrophil lymphocyte ratio in the early diagnosis on acute myocardial infarction. So I don't think that I need to deeply introduce the problematic of acute myocardial infarction and of the rule out or diagnosis of acute myocardial infarction. It is very largely represented among the patients presenting to the emergency department. And currently, as every one of us knows, there is one established biomarker, and it's the cardiac troponin. But what's the neutrophil to lymphocyte ratio? As the name suggests, it's the absolute neutrophil count divided through the absolute lymphocyte count. And it can be a marker of acute stress. In the past years, it gained a lot of attention. It was evaluated also in correlation with cardiovascular diseases or with higher mortality in cardiovascular diseases, but also in many other diseases like infectious diseases or cancer. And why neutrophils in acute myocardial infarction? It's known that atherosclerosis is based on an infectious process. So there is one thing that contributes to the increase of neutrophils in acute myocardial infarction, and also the necrotic process occurring in acute myocardial infarction can amplify the release of neutrophils and hereby increase their absolute count. Despite this, there are no data on the diagnostic performance of the neutrophil lymphocyte ratio together with high sensitive cardiac troponins. So what we did, we used the cohort of EPACE, which is a prospective multicenter international cohort study, enrolling unselected patients presenting to the emergency department with acute chest pain, and the final diagnosis is adjudicated. The EPACE cohort has 6,684 patients, and those patients in which the neutrophil lymphocyte ratio could be counted were 3,476. We assessed the diagnostic performance using ROC curves or receiver operational characteristic curves and counting the area under the curve. And we also assess the prognostic value by doing a survival analysis, which was adjusted for possible confounders. As we can see in this box plot, the neutrophil lymphocyte ratio is mostly increased in the group of patients with acute myocardial infarction in comparison with the other gold standard diagnosis used in the EPACE cohort, but there is also an overlap in between all of the groups. So now to the diagnostic performance. The AUC just for the neutrophil lymphocyte ratio alone is 0.64, which is actually bad. So it seems not to be a good diagnostic biomarker for acute myocardial infarction. And we can also see that it does not bring any additional or incremental value when we combine it with troponin, with high sensitive troponin T. The area under the curve remains the same. For high sensitive troponin T alone, it's 0.94, and in combination with neutrophil lymphocyte ratio, it's still 0.94, which is also confirmed by the DeLong test with a non-significant p-value. The same results can be reproduced when we take high sensitive cardiac troponin I. Also here, there is no incremental value of the neutrophil lymphocyte ratio when we add it to the high sensitive troponin I. To the prognostic value, here we can see a dose response plot, which shows a restricted cubic spline and treats the neutrophil lymphocyte ratio in a continuous manner. The restricted cubic spline has 3 knots in order not to impose linearity. And we can see that the relation between the neutrophil lymphocyte ratio and the outcome, which is 1-year mortality, is non-linear, and that it increases with the neutrophil lymphocyte ratio. That means there is higher 1-year mortality in patients presenting and having a higher neutrophil lymphocyte ratio. So when we summarize it, we have some limitations. In our cohort, unfortunately, there were some informations missing, which would be interesting as possible confounders with neutrophil lymphocyte ratio value. For example, the diagnosis of infectious disease or the intake of some medications which might have an effect on the leukocyte level. And we also excluded patients with terminal kidney failure. And what we can conclude that there is no evidence of an incremental value in the diagnosis of the acute myocardial infarction when we take the neutrophil lymphocyte ratio alone, and when we combine it with high sensitive cardiac troponin T or high sensitive cardiac troponin I. And we can also say that an increased neutrophil lymphocyte ratio correlates with a higher 1-year overall mortality in patients presenting to the emergency department with acute chest pain. Thank you for your attention.
Fascinating data. I really enjoyed that. I always like it when another biomarker goes up against cardiac troponin and fails. But it's a tough ask to beat high-sensitive troponin as on a diagnostic endpoint. But there may still be some value in neutrophils and lymphocytes. And I guess my question really is about the endpoints. As Christian mentioned in the previous presentation, combining type 1 and type 2 myocardial infarction as a non-STEMI endpoint doesn't really allow you potentially to use the value of this biomarker to help discriminate between maybe a type 1 event or a type 2 event, which is much more likely in the context of infectious diseases and other illnesses. Have you reversed the question, looked at the endpoints separately of type 1 myocardial infarction?
Not yet, but our analysis is just at the beginning, so there is some space for deepen it, and we can consider your suggestion.
I think it would be interesting. I think we all are struggling with identifying good biomarkers to differentiate those two presentations. And if there was some insights there, it might be helpful in practice. Second question is, you're also giving, it's pretty tough because if I understand your analysis correctly, it's peak high sensitive cardiac troponin is your comparator, whereas presumably your ratio is only done at one time point. And I assume that the lymphocyte neutrophil ratio, given it as an acute stress response, will also change over time in relation to the onset of ischemic pain and as necrosis develops. So are is it a fair comparison? I guess is what I'm asking.
I mean, this is also something we can consider, but we did not do an analysis for that so far. But I think that it could be a fair comparison, especially because of the necrosis present in myocardial infarction, which also develops in time and not only influences the troponin value, but also influences very probably the neutrophil lymphocyte ratio value. So we could do an observation of the neutrophil lymphocyte ratio in serial measurements.
I think that would be interesting. It also mentioned just to look at the two biomarkers themselves, of course, the neutrophil count and the lymphocyte count, particularly in the prognosis analysis, rather than just the ratio. But really interesting data. In the interest of time, we'll move on to the next presentation. Thank you.
Back to Scotland. We welcome Anda Bularga. Again, my Scottish, I apologize. She's going to present results from the DEMAND-MI study.
Thank you so much. I'm really delighted to be here and to present the results of the demand MI study, which is determining the mechanisms of myocardial injury and the role of coronary artery disease in type 2 myocardial infarction. And it's been topical, isn't it? So we asked 2 questions about type 2 MI. So hopefully it'll be of interest.
You'll just have to describe the findings on the MRI scans to us.
Is it?
Ecco qua.
Sorry?
You can, no, don't touch anymore. You can speak.
That's fine. Yeah. So I have no disclosures of interest. That will be the next slide. Yeah, but the slides are not moving, sorry. Oh, that's fine. Okay, sorry. I always have this, just terrible at technology. Apologies about that. So type 2 myocardial infarction is defined as myocardial ischemia in the context of an acute illness usually, and this is due to increased oxygen demand or decreased supply. This can happen due to a number of different causes of supply-demand imbalance. We now know that established risk factors for coronary artery disease and type 1 myocardial infarction are also associated with type 2 myocardial infarction. We also know that patients with type 2 myocardial infarction have poor clinical outcomes with high mortality rates. Despite our increasing knowledge on the presentation and the outcomes of this condition, this remains clinical challenging in day-to-day practice. Furthermore, we lack evidence to support the investigation, but also the management of patients who present with this condition. So to address some of the challenges related to this, the demand MI study was set up as the first prospective study to systematically evaluate the mechanism of myocardial injury and the role of coronary artery disease in patients with type 2 myocardial infarction. So the study aimed to recruit 100 patients and perform cardiac imaging, coronary and structural cardiac imaging in these patients. From January 2018 to October 2020, we screened 8,000 patients that were admitted to the Royal Infirmary Hospital in Edinburgh with an elevated high sensitivity cardiac troponin I sex-specific threshold, and we identified 702 patients that met clinical criteria for a type 2 myocardial infarction. After the exclusion study criteria were put in, we imaged 100 patients who underwent coronary imaging through the form or invasive or CT coronary angiography and structural imaging. The majority had a cardiac magnetic resonance imaging, and some patients had an echocardiography. Following completion of the study imaging, all 100 cases were reviewed by an adjudication panel, and the final diagnosis was adjudicating using the 4th universal definition of myocardial infarction. So coronary and structural heart imaging allowed us to reclassify 7 patients, and 4 of these were diagnosed with a type 1 myocardial infarction. So the primary outcome of this study was to evaluate the prevalence of coronary artery disease. And in this study, patients with type 2 myocardial infarction, 2/3 had evidence of atherosclerotic coronary artery disease, and this was obstructive in 1/3 of the patients. We also identified important patterns of coronary artery disease, patients having free vessel obstructive disease, similar to the images, the coronary images, invasive angiogram images that you can see here on the slide. These are all from the same patient, a patient who came in following a fainting episode while at a Zumba class, and her CAF showed that she had chronic free vessel obstructive coronary disease with no evidence of disruption, plaque disruption, and she went on to have coronary artery bypass surgery. So the secondary outcome of the study was to evaluate for the prevalence of the mechanism of myocardial injury, also to look at the evidence of imaging evidence of myocardial infarction, and this was defined as late gadolinium enhancement in an infarct pattern on the MRI or regional wall motion abnormality in keeping with ischemia. So This is an alluvial plot on this slide here, and the plot is stratified by the evidence of myocardial infarction. So red for yes and blue for no. And on the left-hand side, you can see the cause of the primary cause of the type 2 myocardial infarction. And then the second column is your coronary artery disease stratification. And the final column shows you the final adjudicated diagnosis. Perhaps one of the most striking findings of the study was that slightly less than half of the patients with a diagnosis of type 2 myocardial infarction had evidence of infarction on imaging. We also identified some other patterns of myocardial injury and some structural heart disease, things like dilated cardiomyopathy, hypertrophic cardiomyopathy, valvular heart disease. And also importantly to mention that 1/3 of the patients were identified to have left ventricular systolic impairment. And these brings us to some important clinical implications. So the majority of patients who were identified to have coronary artery disease or left ventricular systolic impairment, this was not previously recognized. And you can see here that as of the 68% of patients who were identified to have coronary artery disease, less than half of these were on secondary prevention or evidence-based treatment. The same case was for left ventricular impairment. And again, this brings us that there are some important clinical implications with possibility of introduction of evidence-based medical therapy. So in conclusion, coronary angiography demonstrated that 2/3 of patients with type 2 myocardial infarction have coronary artery disease, which was obstructive in 1/3. Less than half of the patients who met the clinical criteria for a diagnosis of type 2 myocardial infarction had evidence of imaging evidence of myocardial infarction, which has implications for the definition of this condition. Most patients identified as having coronary artery disease or left ventricular impairment were not on established medical therapy. So cardiac imaging should be considered in practice to confirm the diagnosis of type 2 MI, but also to guide targeted evidence-based therapies. I'd like to thank the team that worked on the trial, Dr. Chapman, Professor Mills, Professor Dweck, and also just say that we're putting together a supplement that will have all the 100 cases in an online supplement, and it will demonstrate both the clinical presentation, but the imaging studies as well. Thank you for your attention.
Thanks for this excellent presentation. Quick question. Why did you exclude 240 frail older patients?
Very, very good question and good spot. So to be able to, to allow patients to have the investigations, the cardiac MRI, which can be quite a demanding scan, the same for the coronary imaging, we decided that this would be appropriate criteria. As you know from your practice, a lot of the type 2 myocardial patients are frail, elderly patients, so we had to consider that in best patient interest.
Christian.
Congratulations to your important words. I think it's fantastic to now have also imaging data in our biomarker world, and I think the two methods nicely complement each other. I have two questions for you, if I may. So your main finding that 50% of patients with type 2 did not have late gadolinium enhancement or edema in the MRI. Does it mean they didn't have myocardial infarction, so no cells had died? Or is it related to the limited sensitivity of MRI as a method versus troponin? That was the simple question. And then the second question is, you nicely mentioned, showed a lady with the terrible free vessel disease, and she came with fainting. What do you assume was the mechanism of fainting in this lady?
Thank you very much. Two very, very good questions, Professor Miller. So the first one was regarding the evidence of myocardial infarction on imaging. And this is particularly what we are discussing at the moment and debating. I think it's a very good point. I think it's a very good learning point, because if we think about the diagnosis of type 2 myocardial infarction, at the moment, this is a clinical diagnosis. And really what we rely on is on that symptom or sign of ischemia. And the question that I would put is, how important is this when defining this condition? I think that we could rely clearly on the imaging studies that we have from previous data, from previous imaging studies in type 1 myocardial infarction. But this, I think, will be a very important message to take home. Second questions was regarding the lady with the fainting. So we went through that case many, many times. It was a clear story of vasovagal syncope with prodrome of symptoms as well. And it well may be that she had a hypotensive hypoperfusion episode that triggered her type 2 myocardial infarction in the context of her established chronic severe coronary disease.
Salvatore.
Yes, congratulations again, Anna. It was really wonderful, research. You concluded carefully that the majority of these patients, they have a coronary vessels disease. But on the other side, you simply concluded there was a kind of left ventricular dysfunction. Do you mean it is a imbalance because of Laplace regulation that is a stretch in the ventricle? What is the conclusion? That means it's like hypertrophy. Where is this diagnosis coming from? Is it stress or left ventricular function?
Yeah, so it was the left ventricular dysfunction was, some of them was in the context of severe coronary artery disease, so it was a kind of an ischemic cardiomyopathy pattern. There were people also with dilated cardiomyopathy and severe left ventricular dysfunction by imaging analysis, and your symptoms by plain on echo and also MRI findings. So it's in the context of that.
Thank you, and I think in the interest in time we'll move on, but that was really excellent presentation. So if I could welcome Ana Sanchez to this platform, we're going to revert back to novel biomarkers. This one you may have heard of before, glucose, and its role in the early diagnosis of myocardial infarction. Thank you, Ana.
I'm not sure if it's working.
We can hear you, and your slides have just arrived. So.
No, I meant the microphone. That was it. Okay, so thank you very much for your kind introduction, Professor Mills, your chairs, dear colleagues. My name is Anna Jufera, and I'm a research fellow at the Cardiovascular Research Institute in Basel. And today I'd like to present to you our work on the incremental value of glucose in the early diagnosis of acute myocardial infarction. It is no news for anyone here that acute myocardial infarction remains one of the major causes of death worldwide, despite all the improvements in its diagnosis and treatment. For this reason, its rapid diagnosis is critical, and also the rapid identification of low-risk patients is not only of great medical relevance, but it can also help us lower the costs in the ED and lower the length of stay of these patients. The algorithm for the triage of acute coronary syndrome recommended by the current guidelines includes clinical assessment, 12-lead ECG, and serial measurements of high-sensitive cardiac troponin. But it does not recommend the use of other biomarkers for diagnostic purposes. Other biomarkers may be used for, in order to obtain prognostic information. However, several studies have suggested that glucose as a widely available biomarker that is or with a higher expression in stress situations and acute diseases might be of help for the early diagnosis of acute myocardial infarction. For example, Greenslade concluded that the use of high-sensitive cardiac troponin I and glucose was of help to lower the number of patients that needed further assessments in the ED and to lower the number of inpatients. Short came to a similar conclusion in his work published in 2017. For this reason, we aimed to test this hypothesis in a large multicenter study. For this, we also used the APACE study cohort, which is a prospective multicenter international study with the aim to improve the management of acute myocardial infarction. We recruited adult patients presenting to the emergency department with symptoms suggestive of acute myocardial infarction. The adjudication of the final diagnosis was performed centrally in the core laboratory according to the 4th universal definition of myocardial infarction. More specifically, 2 independent cardiologists reviewed all available medical records, including serial measurements of high-sensitive cardiac troponin, cardiac imaging, and follow-up data. For this analysis, we defined our primary endpoint as the diagnostic performance of the combination of glucose and high-sensitive cardiac troponin T and I when compared to just troponin alone for the early diagnosis of acute myocardial infarction. We assessed this by comparing the areas under the receiving operating curves. We defined our secondary endpoint as the prognostic value of glucose for all-cause mortality at 30 days and 2 years. We addressed this with a Cox regression where we modeled continuous variables used in restricted cubic splines in order not to impose linearity to continuous variables. For this analysis, we took all patients where a 0-hour value of high-sensitive troponin T, troponin I, and glucose was available. This gave us a total of 5,639 patients eligible for this analysis. Now going to the results, we first wanted to take a look at the distribution of glucose in our different diagnostic groups from left to right: acute myocardial infarction, unstable angina, cardiac but not coronary reason, non-cardiac, and unknown. As you can see, there is an overlap in most of the diagnostic groups with a bigger difference, of course, in the group of patients that ended up having an acute myocardial infarction and those ones that ended up with a non-cardiac diagnosis. This is in line with the findings we saw in our ROC curves. As you can see, glucose, which is represented by the green line, had a low discrimination for the diagnosis of acute myocardial infarction, not surprising, with an area under the curve of 0.4. A much bigger diagnostic accuracy was seen for both high-sensitive cardiac troponin T and I alone, but most importantly, when adding glucose to both of the high-sensitive cardiac troponin assays, the diagnostic performance was not better. Similar findings were obtained when looking at our subgroup of early presenters. Now let's move on to our prognostic outcome. Here you can see a dosage response plot, which is showing the results of our Cox regression for our outcome of 30-day all-cause mortality. So here on the x-axis, you can see the glucose concentrations. In the blocks plot, you can only see the distribution in our population. So it is important to note that 75% of our patients had values of glucose between 5.4 and 7.2 millimole liter. On the x-axis, on the y-axis, you can see the Hazor ratio, and the red dotted line represents our reference point, which was defined as 5.6 millimole liter, which is the American Diabetes Association cutoff for impaired fasting glycemia. So the main thing you can see in this figure is that you can see the Hazor ratio for every single glucose value. In this case, we observed that from a value of 6.5 millimole liter, there is a statistically significant higher risk for all-cause mortality. The values used to adjust the models were defined based using previous literature research and based on matter-based knowledge. As you can see, for our all-cause mortality outcome at 30 days, at 2 years, we obtained very similar results. Of course, like all studies, we have some limitations to report. First of all, we have no information on the fasting status of the glucose values used for this analysis. So there might have been some values that were over the normal cutoff due to postprandial measurements. This study was conducted in patients that came to the ED, so in an ED setting, and we cannot comment on the performance of glucose in different clinical settings. And third, these findings cannot be generalized to patients requiring dialysis, since they were not included in this study. Now, to sum up, our findings were in line with the current guidelines. Glucose did not improve the diagnostic performance of high-sensitive cardiac troponin T or I for the diagnosis of acute myocardial infarction when studied as continuous variables. When used in early presenters, glucose also failed to improve the diagnostic accuracy of both high-sensitive cardiac troponin T and I. And finally, glucose is a prognostic factor for all-cause mortality at both 30 days and 2 years for patients presenting to the ED with suspected acute myocardial infarction. Thank you very much for your attention. And maybe anticipating the question of Professor Mills, we did not study also for outcome type 1 and type 2 myocardial infarction. However, it's a great suggestion that we will for sure
I'm that
take into
predictable.
account.
I'm that predictable. So I was going to ask you, in addition to that question, were you surprised by your findings, but in terms of its diagnostic performance?
Not really. I mean, I guess the main added value of all new biomarkers or older biomarkers that may be considered now for acute myocardial infarction is more for the group of early presenters, which is still the group of patients where we are in the moment not able to make a quick rule out. For all other patients, I think, I mean, it's just, as you said before, it is very difficult to beat troponin.
So you're familiar with Pete Kavsak's work in this area, you combining glucose and creatinine and troponin as a triple rule out strategy. Have you looked at that in your cohort?
Well, I am familiar with the results, but we did not see this in our cohort. But again, thank you for the suggestion. It is, of course, something we can take a look at.
Okay. One last question, if we've got. Those are excellent. I will pass the microphone to Oscar.
I don't hear.
Nice presentation, Anna.
Thank you.
Just one question. Have you compared the curves of glucose in terms of prognostic factors in diabetic and non-diabetic patients? Because I'm thinking in other circumstances, a rising in glucose is a better marker of worse prognosis in non-diabetic patients rather than the diabetics. Are you looking at that? I mean the restricted spline curves.
No, that we did not look for their prognostic outcome. No, we did not look for that. But again, great suggestion.
Okay, to try and keep on time, thank you very much, Anna. That's really Luca, is Luca here? He's online.
Luca,
excellent. Oh, here
Luca is in Basel. I'm very
the
sorry for
operator.
that. So hello from Basel. I hope you can see me and I hope you can hear me. Can I just have a short confirmation that everything is good? So I hear only Christian, but if he shouts perfect, so I'm thinking everything is good. Okay. So dear Professor Mills, dear Professor Nickel, I'm truly sorry, dear friends and colleagues, that I am not able to attend this year in person at the great meeting. But as long as we cardiac surgeons still have some work left and the cardiologists are not stenting everything, I'm happy to be on call. And that's the reason why I cannot be in Rome together with you. However, I'm very happy to talk today about the ESC01, our algorithm criteria for a novel high sensitivity cardiac troponin I assay. These are my disclosures, but the more important disclosure slides are these one here. I'm truly grateful to be a part of the fantastic research team of the Cardiovascular Research Institute in Basel. And I'm very happy to be a part of the great network with great researchers, but of course also great soccer players. As you all know, lately, several novel high sensitivity cardiac troponin assays have been developed. And before their introduction into daily clinical routine, it's mandatory that these assays are validated in large clinical trials. Furthermore, the ESC01, our algorithm, is assay specific, meaning we have to derive and validate new cutoff criteria whenever a new assay is introduced. Therefore, the aim of this project was to assess the diagnostic accuracy of the high sensitivity cardiac troponin I XL assay, and in a second part to derive and validate an assay specific 01 hour algorithm. To address these questions, we use data from our large international APACE trial, where patients are included when they presented to the emergency department with symptoms suggestive of acute MI. Final diagnoses were adjudicated by 2 independent cardiologists applying the 4th universal definition of myocardial infarction, using all available medical records up to a 3-month follow-up, including serial measurements of high sensitivity cardiac troponin. For this analysis, since we aimed to validate a troponin I assay, we used serial measurements of high sensitivity cardiac troponin I architect for central adjudication for the primary analysis, and performed a secondary analysis using serial measurements of high sensitivity cardiac troponin T for central adjudication. A few words about the assay. The high sensitivity cardiac troponin I XL assay has a limit of blank of 1.1 and the limit of detection of 2.7 nanograms per liter, and the combined 99th percentile of 60.4 nanograms per liter, slightly higher for male and lower for female. In our study, we included 1,454 patients representing a typical chest pain cohort with a median age of about 60 years, a quite high amount of early presenters, meaning presentation within 3 hours after chest pain onset in about 40% of the patients, and a prevalence of non-ST elevation myocardial infarction, about 14% of the patients. Now here you can see the concentrations of the troponin I at presentation according to the final diagnosis: acute myocardial infarction, unstable angina, cardiac not coronary chest pain such as heart failure or rhythm disorders, non-cardiac chest pain such as musculoskeletal pain, and unknown pain. As expected, the median troponin concentrations were significantly higher in patients with an adjudicated myocardial infarction compared to patients without an acute myocardial infarction. Now, the diagnostic accuracy of the troponin I XL assay was very high, with an area under the curve of 0.94, and a comparable performance compared to troponin I architect, and even statistically superior to troponin T Alexis when using serial measurements of troponin I for central adjudication. Also, in the vulnerable subgroup of early presenters, the diagnostic accuracy was very high, with an area under the curve of 0.93, and again, a comparable performance to troponin I architect and troponin T Alexis. Now, as said before, these findings were confirmed in a sensitivity analysis using serial measurements of high sensitivity cardiac troponin T instead of I for central adjudication. And again, in all patients, as well as in early presenters, the diagnostic accuracy of the troponin I XL assay was very high and comparable to troponin I architect and troponin T Alexis. So for the second part of this project and the derivation and validation of the troponin I 1-hour algorithm, we of course had to exclude all patients where we did not have a 1-hour level of the troponin I XL. To be consistent with previous published papers, we randomly split our data set to a derivation group and a validation group in a relation of 70 to 30. As before, we aimed for a predefined negative predictive value over 99% for rule out, and a predefined positive predictive value over 70% for rule in. Applying the here presented cutoff criteria, we were able to rule out about 60% of the cohort with a very high negative predictive value and a very high sensitivity, and no missed patient with acute myocardial infarction. We could rule in about 10% of the patients with a high positive predictive value and a high specificity. 1/3 of the patients remained in the observed zone, meaning they could not be triaged into rule in or rule out after 1 hour. Similar findings were seen in the validation cohort. Again, about 60% of the patients could be ruled out, about 10% of the patients could be ruled in, and about 1/3 of the patients remained in the observed zone. However, in the validation cohort, 1 patient with an adjudicated myocardial infarction was missed, leading to a negative predictive value of 99.5%. This 1 patient was a patient with a type 1 myocardial infarction. It was an early present with chest pain onset before 2 hours, meaning we missed him here in the second part of the rule out component, and we missed him because of a low delta of 4, which was below the cutoff of 5. Last but not least, I want to show you the overall survival according to the 3 groups: rule out, observed, and rule in. And what we can see is a very high 30-day survival of 99.8%, and a very high 730-day survival of 97.1% in the rule out group, showing the safety of the rule out approach, and lower survival rates in the observed zone and in the rule in group. Now, what are the limitations? We need further studies to quantify the utility of the rule-out and rule-in strategies in patients with a higher or lower pre-test probability, meaning in another setting than the emergency department. Further studies applying these diagnostic algorithms prospectively for clinical decision-making are needed. And as general for the APACE trial, we cannot generalize our findings to patients with terminal kidney failure requiring dialysis, since these patients are excluded. However, I want to summarize that the diagnostic accuracy of the high sensitivity cardiac troponin I XL assay was very high and comparable to the both most widely validated assays, troponin I Architect and troponin T Alexis. These findings were consistent in the group of early presenters and when using serial measurements of high sensitivity cardiac troponin T instead of I for central adjudication. The derived and validated algorithm showed a high safety and accuracy for rule out and rule in. However, 1/3 of the patients remained in the observed zone, which is slightly higher compared to other assays. And with this slide, I want to conclude and thank you very much for your attention.
Thanks, Luca. Can you hear me okay?
Perfectly.
Yeah, a lovely presentation. Delighted for the patients and for the Italian great football team that you are not able to be with us. But we enjoyed your presentation. The question I wanted to ask you really was about the gold standard. I thought it was really interesting that you applied two different approaches there. Just talk me through your thinking.
Absolutely. So as you said correctly, we have two ways, or there are two ways for the gold standard diagnosis of a central adjudication, meaning for one, we used additionally to all available medical records up to a 3-month follow-up and including study-specific records such as specifically chest pain characteristics, we use serial measurements of high sensitivity cardiac troponin T. However, when using troponin T assay for the central adjudication, this may introduce a bias in favor to troponin T when comparing a troponin T assay and a troponin I assay. Therefore, as a second part, or in a different way of the gold standard, or a different way of the central adjudication, we used serial measurements of the troponin I Architect assay instead of the troponin T Alexis assay, so that the gold standard diagnosis is based, besides all medical information, on serial measurements of high sensitivity cardiac troponin I rather than T. We think this is a very important additional quality when using the central adjudication and when comparing different assays.
It's a good answer. It's a really difficult thing to do, isn't it? I mean, particularly when you have a pathway which addresses both rule in and rule out. I guess in practice, when this is applied, the same assay will be used on peak measurements as will be used at the initial triage. Did you consider using peak measurements of the new Siemens assay as your gold standard?
Peak assays in what time period? We have, like for the early rule out and rule in, for the early diagnose, for the early algorithm, we of course needed the troponin concentrations at presentation, and for the scheme of the 1 hour algorithm, of course, the values at 0 hour, so at presentation and at 1 hour. We also have, like in the study-specific assessments and blood samples, we have the peak values up to 6 hours where we could analyze if we would want to. I don't know if I did understand your question correctly.
Additional reassurance for the early rule out of patients to know that the late samples measured with the Siemens assay were also reassuringly normal or below your diagnostic threshold. But it's perhaps it's a minor technical point. Fabulous to finally come up with a biomarker, having seen glucose and neutrophil lymphocyte ratios fail, that is as good as our previous markers. So very nice work. I don't think we have any other questions from the floor, and we are over time. And Christian, I'm afraid, has some bad news to share with the group. So
yes, since I was responsible for Swiss time, the bad news is we're going to have a coffee break, but it's only going to be 10 minutes. So that means we'll meet here back together at 4:30.
Okay. Welcome. We start this next session. I present myself. I am Maria Pia Ruggeri, Chief Director of Emergency Department of St. John Hospital in Rome. And together with me, there are fellows of Emergency School of Professor De Somma. So thank you very much for this invitation to Professor De Somma, to Professor Müller and Mebasa, because this is a very fantastic meeting. I think that now in this session, sepsis, pneumonia, pulmonary embolism, COVID-19 are surely for situation very important in our emergency department. And I think that all the things that our colleagues will tell us will be important for fast diagnosis and fast and appropriate therapy in emergency. So I presented you.
Thank you very much. Thank you very much, Maria Pia. I'm Francesca De Marco, an emergency physician. I'm working in San Giovanni Hospital in Rome. I'm very happy to stay here. Today, I'm grateful to Professor, and I want to thank you for this great opportunity and for the opportunities that you give us every day to our staff. But I don't know, what do you think, Maria Pia? But I think we can start with the presentation. And do you have... Okay. And Daphne Papasidero, Dr. Daphne Papasidero. Okay. Daphne is a fellow of School of Emergency Medicine directed by Professor De Somma, and he's attending her fellowship in our hospital, San Giovanni. So go, Daphne. I'm sorry, the title is a rule of bio-ADM, PANKID, and DPP3 in the management of COVID-19 and non-COVID-19 pneumonia in emergency department.
Good evening, everybody, and thank Professor De Somma for this great opportunity. Thanks, Dr. Ruggeri and Dr. De Marco for this introduction. I am Ilaria Daphne Papasidero, and today I wanted to share with you the results of our research on the role of BioADM and PANKID in the management of COVID-positive or COVID-negative interstitial pneumonia in emergency department. BioADM as can be used as a biomarker of endothelial function and vascular integrity during sepsis, and PANKID is a biomarker of acute kidney injury in septic patients. In this study, we evaluated the prognostic role of BioADM and PANKID in COVID-positive or COVID-negative interstitial pneumonia at arrival in emergency department. In this prospective observational study, we enrolled 157 accessing to San Giovanni Emergency Department in Rome between April 2020 and April 2021. This population is made up of 107 COVID-positive interstitial pneumonia patients and 50 COVID-negative interstitial pneumonia patients. Oh, sorry. We ran basic blood test and biomarker dosage and lung CT scan to the accessing emergency department. After 24 hours, we repeated blood test and biomarker dosage. And then we conducted a telephonic follow-up after 30 days. And the blood samples for biomarker dosage are sent to Sphingotec Labs in Germany to dosage. Our primary endpoint is the 30 days mortality, and secondary endpoint were the clinical worsening during the first day and the occurrence of other adverse events within 10 days. In this table, we can see the clinical characteristics about our patients. And as we can see, there are no big difference in the characteristics of our population. Mortality is the same in two populations, and the only notable difference is in the symptom of presentation in emergency department, because COVID-positive patients presented more than one single symptom to the admission, and COVID-positive patients presented more complication during their follow-up. In this slide, we evaluated the biomarkers value in our population for etiology difference. As we can see in this box plot, there were not a great difference in PANKID and BioADM value in COVID-positive or COVID-negative patients. Then we evaluated the value of BioADM in our population. And as we can see in this slide, BioADM strongly correlates with mortality during the first day, within 10 days, and within 30 days. Then we evaluated PenKid and we confirmed that PenKid elevation is predictor of acute kidney injury in emergency department, as we just now in septic patients. And PenKid value correlates with mortality within 30 days. Then we evaluated CURB65 in our patients. CURB65 is a risk score for using to assess the probability of 30 days mortality in patients with pneumonia in emergency department, dividing them in 3 groups of increasing risk. As we can see in this chart, the risk group of CURB65 correlates with mortality. And as we can see in this box plot, value of biomarkers correlates with risk group of CURB65. This clinical score is recognized in literature as a powerful predictive tool. But in comparison with our biomarkers, we find out that BioADM and PenKid are even stronger predictive tools in pneumonia in emergency department. Studying BioADM is important because we have at disposal adrecizumab, a monoclonal antibody, which is being studied in septic patients. A additional study could be used to prove the possibility of use adrecizumab in pneumonia patients too. In conclusion, in patients with interstitial pneumonia, COVID positive or COVID negative in emergency department at admission, BioADM strongly correlates with mortality at 24 hours, 10 days, and 30 days. PenKid predicting acute kidney injury and correlates with mortality at 30 days. BioADM and PenKid are better mortality predictor than clinical score. Besides sepsis, in the future, adrecizumab could represent a potential therapeutical option for patients with interstitial pneumonia in emergency department. And in the end, future multicentric study in emergency department should be needed to confirm these preliminary results. Thank you for the attention.
Excellent, Daphne. And I think this study could open new scenarios in diagnosis and treatment of pneumonia. Any question? I have a question for you. How did you use another cutoff for BioADM than the one used usually for sepsis?
Okay, thanks for the question. Allora, we for BioADM using 45 nanogram to deciliter for as a cutoff, and this value is the upper limits of normal range, and we using this cutoff and not 15 as in septic patients, because this is no septic patients. This is patients with pneumonia.
Okay. Yes, I think okay. No question. I think we can move on. Next presentation.
Thank you very much. So now I present Silvia Casalboni. Silvia. Okay. Other fellow of the emergency school of Professor Di Somma. Silvia talked about utility of new biomarkers, point of care for the risk stratification in patients with sepsis in emergency department. Thank you.
Good afternoon, everybody. Thank you all, and thanks to Professor Di Somma for this opportunity. Thank you for the presentation. Today I'm going to talk about the utility of biomarkers point of care for risk stratification of patients with sepsis in emergency department. The aim of the study was to evaluate in sepsis patients in emergency department the prognostic value for bioadrenomedulin and proencaphalin A. Pankid is important for sepsis because it rises faster than creatinine in case of acute kidney injury. BioADM is important because it interacts with endothelial cells and smooth muscle cells, modulating endothelial barrier and contributing to hypotension and organ failure. Today is even more important because we have aducanumab, that is a human engineering antibody that can partially inhibit this effect. From May 2021 to September 2021, we enrolled 85 consecutive patients with suspicion of sepsis in the emergency department of Azienda Ospedaliera San Giovanni Addolorata in Rome. For each patient at emergency department arrival, we evaluated clinical history, physical examination, routine laboratory tests, including procalcitonin and C-reactive protein, BioADM and Pankid using a point-of-care instrument called IB10 from Sphingotec, QSOFA and SOFA score, imaging results, diuresis, and need for inotropes. Then we performed a fungal follow-up at 30 days to evaluate adverse events. Nexus IB10 is a point-of-care immunoanalyzer that can measure in whole blood multiple biomarkers. By utilizing this device, we were able to obtain the results of our biomarkers within 20 minutes. As I said, we enrolled 85 patients. The median age was 74 years. 49 of them were male. The median SOFA score resulted to be 3.6. The most common ER disposition word was the low intensity word, but 10.6% of our patients died in the emergency department. The most common septic focus was the lung, and the second one, the urinary tract. 13.1% of our patients needed inotropes to sustain blood pressure, and in all of them, we used norepinephrine. At the end of the follow-up, 25 patients died. At first, we divided our population into groups. The first one with SOFA under 2, and the second one with SOFA over 2. As you can see, there are some statistical significant differences between the two groups. Patients in the second group had a higher percentage of death. Worse parameters at arrival, like a lower ZCS, higher respiratory rate, higher body temperature, a lower PF ratio, high levels of lactates and procalcitonin, and a lower arterial oxygen content. Then we check our biomarkers for values of SOFA. And as you can see, we used the cutoff for BioADM of 70 micrograms per deciliter. A positive BioADM was only found in septic patients, so in patients with SOFA over 2. We didn't obtain the same results with Pankid. That was positive in patients with acute kidney injury, even if they had a SOFA under 2. Then we confronted Pankid with a marker of kidney function. As you can see, Pankid was much higher in patients presenting to the emergency department with oliguria or anuria. And we also found that high values of Pankid at arrival matched with high values of creatinine at arrival. Then we analyzed final disposition from emergency department. And as you can see, BioADM was much higher in patients dying in emergency department. And it was even more predictive than SOFA score and Pankid. Then we used Kaplan-Meier analysis to confront values of Pankid with survival at 30 days. And as you can see, we didn't obtain a statistical significant result. Instead, we did obtain a statistical significant result for survival at 30 days with Kaplan-Meier analysis, both for SOFA score and BioADM values with a cutoff of 70 micrograms per deciliter. The most interesting result was obtained considering Kaplan-Meier analysis for the combination of BioADM and SOFA score, because as you can see, in patients with SOFA score over 2 and BioADM under 70, we had a higher survival rate than in patients with a positive SOFA and a positive BioADM, with a statistical significant result. In conclusion, in patients with suspicion of sepsis in emergency department, SOFA score confirmed to have a risk stratification value for mortality. BioADM obtained with a point-of-care device showed a significant prognostic value to predict 30 days mortality. BioADM and SOFA score seem to have a similar prognostic value for mortality. And from our data, seems that using SOFA score plus BioADM, it's possible to obtain a stronger predictor value for mortality than SOFA score alone. Sepsis patients with a BioADM over the cutoff of 70 could be the ideal candidate for the use of adrocizumab in emergency department. SOFA score use is also been validated only in ICU, but never in emergency department. It requires blood exams, which are often available after 90 minutes, while in our study, BioADM was available with this point-of-care device within 20 minutes. PanKid obtained with this point-of-care system confirmed its role in mirroring real-time renal function. Thank you.
Thank you, Silvia. Very, very interesting. Your relation very interesting because fast time, fast diagnosis, fast and appropriate therapy, new concept in emergency department, very, very interesting. I think there is time for any question if you have curiosity about this. Have you not? So, Silvia, I want to ask you, in your study, did you find, or it seems so a clear relationship between intensity of care and SOFA score and biomarkers? Can you tell something about this? Thank you.
So I think it was more interesting watching at death in emergency department because the intensity care recovery often depended by the choice of the physicians. And even if the parameters matters, I think that the decision of the physician was more important in the choosing in which ward recover the patient. Also, I saw that levels of PanKid was much higher in patients recovered in the medium intensity ward. And I think that is because levels of PanKid matched with kidney failure. And kidney failure is often recovered in medium intensity ward or low intensity ward.
Thank you very much. So, Francesca, I don't know if you have any question or we could go on.
Why did you divide in two groups, SOFA, measure over 2, and or?
Okay, yeah. Thank you for the question. We consider patients with SOFA over 2 septic patients. Patients with SOFA under 2 usually have a better prognosis. And so we divided our population basically in non-septic and septic patients. But as I said, the SOFA score is difficult to apply in emergency department. I think the future is in these biomarkers.
Very difficult, yes, in the real life of emergency department. Okay, I think we can move on with the third presentation. Thank you, Silvia. And I'm happy to present Elisa Cennamo. Elisa is a fellow our School of Emergency Medicine, directed as always Professor Di Somma, and she talks about the tools for final disposition of patients with pulmonary embolism. Please, Elisa.
Thanks for your presentation and thanks for giving me the opportunity of speaking here today. So I'm going to present our study on tools for final disposition of patients with pulmonary embolism in the emergency department. It's not, okay. So as the background of our study, we know from current guidelines that it is mandatory to stratify the patients with acute pulmonary embolism for their mortality risk in the moment of diagnosis. So as we can see from the current SCS guideline, In patients without hemodynamic instability, we should use preferably the PASI score or its simplified version. And we should also assess the presence of right ventricular dysfunction by imaging methods or laboratory biomarkers. Here is the PASI score and its simplified version, which takes into account age, sex, some comorbidities, and vital parameter, and which divides the patients into 5 classes of mortality risk at 30 days, so from very low to very high mortality risk. Here again, from guidelines, we should take into account as indicators of risk for the patient, the presence of hemodynamic instability, the PASI score, the presence of right ventricular dysfunction assessed by imaging methods, so transthoracic echocardiography or CT pulmonary angiography, and the presence of myocardial injury detected by cardiac troponins. But this assessment is considered to be optional if the other parameters are negative. So here the algorithm to follow. In patients with acute pulmonary embolism and without hemodynamic instability, we have 2 first steps to do. First step, do the PASI score. Second step, search for the presence of right ventricular dysfunction by imaging methods. Only if at least one of these 2 first steps is positive, we should perform the troponin test. Otherwise, the patient is considered to be at low risk, and we could think to an early discharge and the home treatment without performing the troponin test. Here, our study design, it was a prospective observational study. We enrolled 83 patients consecutively collected in San Giovanni Hospital in Rome in the emergency department, where the diagnosis of acute pulmonary embolism was made. On the right, the data collected, so besides other routine parameters and tests, for each patient we collected high-sensitive troponin I, the CT pulmonary angiography, the PASI score, and the final disposition made. These are the patient's characteristics. So the majority of them were women with a median age of 78 years old. The majority of them were triaged with a code 2 or 3. And the majority of the patients were in the low or moderate class, according to PASI score, with the prevalence of the low PASI risk classes. The majority of the patients had a positive troponin I, high-sensitive troponin I, similarly to other population previously studied. So we compared the PASI risk class with high-sensitive troponin I, both considered as a continuous numeric variable or the positive negative. And in both cases, we had a positive statistically significant relationship. But if we look into each PASI risk classes, we can see in the low PASI risk class, we have more than 20% of the patients with positive high-sensitive troponin I. We did the same thing comparing some imaging parameters of right ventricular dysfunction with high-sensitive troponin I, so particularly right ventricular, left ventricular diameter and volume ratios SCTPA. In both cases, we had a positive statistically significant relationship. But if we look again into the groups with a negative ratio, we can see that more than 20–30% of the patients had a positive high-sensitive troponin I. So similarly to the PASI score, if we take into account only the PASI score or the presence of right ventricular dysfunction detected by imaging methods, we risk to miss more than 20–30% of the patients. So we looked back at the CT pulmonary angiography from a new perspective, giving importance to the presence of a bilateral lung involvement or the involvement of at least one principal artery. In both groups, we have the majority of patients with a positive high-sensitive troponin I. And we proposed here a new score, perhaps, hopefully, which takes into account the presence of a bilateral lung involvement and the involvement of at least one principal artery. And we divided the patients into 4 groups, so from very severe lung involvement to mild lung involvement. And we compared the lung involvement so assessed with high-sensitive troponin I. As we can see in the group with a very severe lung involvement, we have the majority of the patients with a positive high-sensitive troponin I. So we know from literature that a positive troponin is linked to prognosis. Also in our group of patients, as we can see, the patients who needed an admission to an intensive care unit or a sub-intensive care unit from the AD, so the vast majority of them had a positive high-sensitive troponin I. At the opposite, only few patients who needed an admission to a low-intensity care unit had a positive high-sensitive troponin I. So in conclusion, our study limitations are the small sample of patients and the absence of follow-up and 30-day mortality data. But from our preliminary study, we can say that in patients with acute pulmonary embolism, high sensitive troponin could be recommended in order to properly stratify the patient's mortality risk, even in the presence of a low PACE score or a negative right ventricular involvement at imaging. And an easy-to-use CTPA score able to predict the presence of myocardial injury, particularly according to high-sensitive cardiac troponins, could be very useful, but further studies are needed to validate the score here proposed. And further studies are also needed to compare the use of natriuretic peptides, imaging, and high-sensitive cardiac troponins for this purpose, and hopefully to use a validated score which combines all these aspects together. Thanks for the attention.
Thank you, Elisa. Very, very interesting. And a small patient sample, it could be a good occasion, situation, this to have a prospective multi-center study together with the other colleagues. I don't know, have you some questions, some curiosity? Because I would like to know, Elisa, small patient sample, I understand, but do you think that this new score, but which you talked, can really add in the future important tools to the evaluation of pulmonary embolism in emergency department, in emergency situation?
Yes, thanks for the question. I think that we have two scenarios. One scenario that is in our overcrowded emergency department. So we know that in order to do the diagnosis of pulmonary embolism, we already do the CT pulmonary angiography. So if we have an easy to use tool, which we can do as emergency physician in the emergency department, which correlates with prognosis or with myocardial injury, particularly according with high sensitive cardiac troponins, could be very useful, even in those places where we still not have high sensitive troponins. So probably it could be useful, but we need further studies in order to validate the score here proposed.
Please, Professor, yes.
Congratulations, Elisa. I mean, I'm congratulating the group, first of all. You are doing a fantastic job. Thanks from my side. You say many times, thanks to me, but I really would like to thank you, taking the opportunity. I think that one of the importance of the study, like Professor Masip was just underlined, that you are going the risk to send at home patients that are high risk to die, right? Because with my friend Frank Peacock, already we decide that when you have patients high sensitive positive, whatever is the reason, you should not send at home. And I think from this point of view, I really encourage other groups to participate in this. Is the time to check high sensitive troponin, because the data that guidelines recommended are based on the regular troponin. So I think there's room now to use properly the concept that you don't want to send at home patients with high sensitive troponin. What do you think, Frank?
So we did a prospective emergency department pulmonary embolus discharge study 3 or 4 years ago, which at the time was considered very radical, but we did not use the PESI score. There are things in PESI you can't know in the ER, like the history of cancer and all that sort of stuff. And also we're going to keep all the sick ones. People with big PEs, people with saddle embolus, they're not going home, even if they look great. And we use a score called Hestia. And the advantage of Hestia is it's only for well people. It's not for the sick ones, because I'm keeping all the sick ones. And we excluded everybody from our trial if they had an elevated troponin, because I agree with Sal. If the troponin's even the slightest bit elevated in the center of PE, they're sick, and you got to decide what you're going to do for them. But great study, and like she said up there, I'll be part of a prospective evaluation with you one of these days.
Thank you very much, Lisa. Any questions? No. So I think that we can move on with the first presentation.
So I present Marianna Nigro, which is another fellow of Professor Di Somma, School of Emergency Medicine. I want to cite Professor Mebaza before this session told that after the Pope there is Professor Di Somma in Rome. Before, I'm sorry, Professor. So, only to joke. Marianna? So Marianna talked about rapid detection of hemolysis for point of care test, blood gas analysis. Thank you.
Thank you, everyone, and good evening. I would like to thank Professor Salvatore Di Somma for this big opportunity, and I would like also to thank Dr. Ruggeri for this introduction. I would talk about the rapid detection of hemolysis for in emergency departments. The healthcare system is increasingly relying on clinical laboratory data that unfortunately are not free from errors. Hemolysis as a pre-analytical error is the most frequent of it, and in fact, it seems to be present in around 2 to 10% of blood gas specimens analyzed in a central lab. As we can see from this graphic, a study of 2009 of Lippi et al. Demonstrated that the majority of the hemolytic samples in a lab were coming from the emergency department. This is happening also because the POCT devices used in the emergency department are not considering the presence of hemolysis. And also, it could lead to a wrong decision based on reliable data. So we designed a study that has 3 main aims. The first one is to analyze the prevalence of hemolysis in blood gas samples using a POCT analyzer in ED. This study started in March of this year. We are still collecting samples and is also the topic of this speech. The second aim is a method comparison study that used this device that you can see in the picture below and the Abbott Architect that is our reference method in our lab. The third part is to perform a user evaluation study regarding the user friendliness of the device with a survey. As you can see, MCheck has developed a point of care system for immediate hemolysis detection that is designed to search free hemoglobin in plasma and consists of an S test, a V test, and an H10 reader. We have a target sample of 700 samples obtained in emergency department by any patient undergoing an arterial or venous blood analysis for acute diseases in emergency department of San Giovanni hospitals in Rome. The exclusion criteria are, for example, insufficient amount of blood for the hemolysis test and visible clots in the syringe and so on. The operator has to perform the sampling and then has to perform the hemolysis test. After, he had to collect the data from the hemolysis test and also the data coming from the usual analysis. After, he has to tell to the health worker the results and has to collect the decision before and after the healthcare workers knows the response from the hemolysis test. These are our patients' characteristics. We collect until now 225 arterial samples, and 26 of them came back as hemolyzed, and 199 not hemolyzed. So we have an hemolysis frequency of 11.6%. The majority of our patients were men, in fact, they were 53% of them, and we divided also the patients for triad symptoms, and the vast majority obviously had dyspnea as presentation symptoms. We also have done a research for hemolysis in each group, but we couldn't find a statistically significant relationship between the underlying disease and the presence of hemolysis. These are our preliminary results, and as we can see, important values are influenced by it. In fact, we can see an important increase of potassium and an important decrease in PO2. And 3 values came back as statistically significant as potassium, pH, and PO2. So this could definitely lead to a wrong clinical decision if hemolysis it goes undetected. Also from this graphic, we can see how hemolysis is varying by individual operator, but obviously we know that as a pre-analytical error, hemolysis is strongly dependent on the skills of the operator. So obviously training is definitely important in a department as the emergency one that has a lot of workers in it. Also, we collect the decision that were made from the by the healthcare workers after the knowing that the samples were hemolyzed, and as we can see, 58% of them modified their decision. And so there is room for improvement if hemolysis is detected. In conclusion, hemolysis is frequent in blood gas samples, and is therefore important to identify hemolysis as soon as possible, especially in the emergency department, where time management is highly important and critically ill patients are more prevalent. Hemolysis impact important blood gas analysis results, such as potassium, pH, and PO2, and operator variance is also an important factor. So we have some intents. We want to continue the project collecting samples for this part of the study and the next 2 parts of the studies. We want to promote a new study to understand better how much hemolysis can be influenced in matter of time and clinical decision in ED. And we want to invest obviously more resources in training for the healthcare staff. And it is important to learn to detect hemolysis sooner and with more precision to improve the management of the critically ill patients. Thank you.
Excellent, Marianna. And any question? Please.
Thank you, excellent presentation. How could you distinguish between hemolysis because of the technique of taking samples from real hemolytic problem of the patient?
Yeah, so we had this tool that is, I can show maybe with the slide the tool. The MCheck developed this system that was really easy to use, and actually we tested the samples, and we have a system of 2 green lights, 2 lights, a green light that it's saying that the sample was not hemolyzed, and a red light that said that the sample was not hemolyzed. So it was pretty easy to understand if the sample was hemolyzed or not.
Okay, yes. Yes.
So, Marianne, the question from Professor Massico was a little bit different.
Yes.
Because this was asking, how can you distinguish on the reason of hemolysis if there is a pre-analytic error, right?
Yeah.
Or let's say intravascular hemolysis before, right? So the question is how much you can distinguish about the hemolysis that was done because of error of the operator, or seems be done because of the disease. It seems from the results you show that there is some relationship with the infection. So it seems that the infection
it was
is
not significant, actually.
but was not significant. So it seems that the majority is due to error in taking blood.
The graphic that shows the prevalence.
Sorry, but I was just
hemolysis
addressing Dr. Masi's question.
from hemolysis, we also checked each one of the operator that was participating to the study. And actually from a graphic that I've shown, you could see that there is a variance between operators. So that's why we can see that.
Okay.
Thank you very much for this. Thank you. Thank you very much for the presentation of this very interesting data. I was just wondering, you said that 58% of the operators changed their management strategy of the patient, depending on the fact if the sample was marked as hemolytic or not.
Yeah.
But so the operator knew that the sample was hemolytic, but based on what did they change their management on the patient? Did they perform another blood sample analysis, or how did they do it?
No, actually we tricked them. So we gave before the results without telling them if the sample came back hemolyzed or not. After they have take some decisions, we have told them that the sample was hemolyzed or not. And so we collect also the decisions that they have made after.
But did you actually redo the sample and check if there was hemolysis
In
again?
some cases, yes. In some cases, yes. We have done again, we have resampled.
I think it's very important because I'm an emergency physician and I know, you know, many decisions are taken by hemogas analysis, no? So it's a very interesting study. Any question?
So as my understanding, this machine cannot tell you why they're hemolyzed. And the most common one is operator error. So we just repeat it. The less common one is spurious. That's spurious. The less common one is pseudo hyperkalemia that occurs in patients who have very high white cells, very high platelets, hereditary spherocytosis where they have very fragile cells. And there's a trick for that. All you have to do is use a blood glass syringe so there's no suction, so the cells don't break. And then you do a point of care analyzer, so there's no centrifuge, so the cells don't break.
Yeah.
And that you will have a normal potassium. When you first pull it, it'll get a potassium like of 7, and you'll think it's hemolyzed. So, but this should work if you prepare the sample correctly. So if you have an elevated, you think it's hemolyzed, and then you do the other technique with the blood gas and the point of care, you should get a normal reading on this machine.
Yeah, definitely is interesting.
Again, Mariana, the question that was coming from the floor was not completely well addressed. He was asking the methods, right? And I think is something that we have to clarify. So the project was designed in double blind. So the operator was not supposed to be alerted by the presence of hemolysis because it was observational. Then this is the way that we are making the study. So officially, this is not allowed. But then after that, they came up and said, this is hemolysis, you want to recheck. And then after recheck, he was thinking to recheck again and send to the central lab. So this is a little bit biased on the design, but the design was correctly, and we are making the same for next 700 patients to make double blind. That is the way that you really want. But now the next step is compare with the central lab, because in point of care blood gas analysis, not get the chance. And I really enjoy what you say, Frank, to use appropriate in the future and see if it is really due to technology that you use to take syringe, because I think this will be also important in the future. But at the end of the day, it's something there that we should check.
Okay, thank you very much.
Thank you.
We must go on, and I present Christoph Kaufmann from Austria. Welcome. He talks about biomarkers for prognostication and COVID-19.
Okay. First of all, I would like to thank the organizers and the panel for the invitation. And I'm very happy to talk about cardiovascular biomarkers and myocardial injury in particular in patients with COVID-19. And I will also give you a brief overview of our own research findings in this subject. I do not have any conflicts of interest to declare. When we talk about cardiovascular biomarkers in patients with COVID-19, we have to consider that there has been quite a bit of research in this matter. We have several biomarkers that have been identified to be of prognostic value in these patients. These are just a selection of a few regular ones, common ones used. We have high sensitive cardiac troponin I or T as a marker of myocardial injury, NT-proBNP as a marker of natriuretic peptide. Of course, there's D-dimer, which is linked to thrombosis and thromboembolism, and then some other less used biomarkers. When we're talking about pathophysiology of myocardial injury in patients with COVID-19, I think we have to consider the fact that we do have lots of hypotheses, we do have lots of potential mechanisms that might explain this association. However, we do not have any direct causal relationship that has been identified yet for this association. Just to name a few without going into detail, I think we can look at oxygen supply-demand imbalance. We can look at inflammation-related injury to the heart. We also have to consider micro and macrovascular thrombosis and thromboembolism, and also, of course, direct viral admission to the heart. So this is just one of many studies published on this subject of myocardial injury in patients with COVID-19. We do know from meta-analysis that the true prevalence of myocardial injury in these patients, especially among hospitalized patients, is roughly about 15 to 20%. We also know that the outcome of these patients is significantly impaired. Now, we again look at a meta-analysis that summarizes these findings, and we can see an almost universal finding of increased mortality among patients with higher levels of cardiac troponin I or T. Now, this leads me to our own research findings, and I'm happy to show you a brief overview of our study that was performed in Vienna, Austria, with the title Improvement of Outcome Prediction of Hospitalized Patients with COVID-19 by a Dual Marker Strategy using both high-sensitive troponin I and copeptin. Now, why did we choose copeptin as a biomarker of interest in this setting? Well, copeptin has been established as a biomarker of stress and has been of prognostic value in a plethora of clinical conditions, including pneumonia, critical illness, and cardiovascular disease in particular. I already said it's a prospective observational single-center study that was performed in a tertiary hospital in Vienna, Austria. We had a total of 223 hospitalized patients with laboratory-confirmed SARS-CoV-2 infections. So all our patients had PCR done. We excluded 10 patients because of missing laboratory values. And all patients presented to the emergency department between June and November 2020. So we have a good appreciation of the second COVID-19 wave in Austria. The primary endpoint of our study was a composite of admission to the ICU or all-cause mortality within 28 days. And the key secondary endpoint was 28-day all-cause mortality itself. Now let's have a quick look at the baseline characteristics of our study population. And we can see that those patients with an adverse event were significantly older. They also had more comorbidities. This is quite a likely finding. We have more hypertension, we have more history of cardiovascular disease, and we have more chronic kidney disease. Patients who died within the follow-up or were admitted to the ICU also suffered from dyspnea more often. And then when we look at the routine laboratory measurement in these patients, we see a strong inflammatory axis. We see higher levels of white blood cells, higher neutrophil granulocytes. We also see a higher neutrophil to lymphocyte ratio. We have talked about that today already. Of course, CRP as well. And also creatinine and LDH, both markers of risk in patients with COVID-19 that have been well established before. So what are the results of our study? Just one quick look at the levels of troponin and copeptin show us that both biomarkers were significantly increased in patients with an adverse event. Now, when we look at the statistical analysis, we did this both on a dichotomized and on a continuous level for both biomarkers, and we adjusted in model 1 for age and gender, and then in model 2 for comorbidities and clinical signs and symptoms of COVID-19. And we found persistent, significant results for both copeptin and high-sensitive cardiac troponin I in both groups, both on a continuous level and on a dichotomized level. And we also found that the combination of high troponin and high copeptin yielded in the highest odds ratios of all patients. So what we now propose is a risk reclassification system. I hope you can see it is rather small, but again, we had 213 patients hospitalized with COVID-19. We had an adverse event rate of 25% within 28 days. We then performed stratification of our patients according to levels of troponin first. So those with high troponin had a significantly higher adverse event rate. We're looking at 44 to 45%, whereas those with low levels of troponin were only at 13%. And this is where the copeptin comes in as a second risk stratificator. And we looked especially at those patients with high levels of troponin, and we found that the group of patients with an increase of both biomarkers constituted a high-risk group with an adverse event rate of roughly 55%, whereas those with high troponin and low copeptin had comparable event rates compared to the group of patients with a low troponin to begin with. This association remained persistent for the key secondary endpoint of 28-day mortality itself. And when we look at our graphic, we see again 24 of 59 patients died in a group of patients with high levels of both biomarkers, whereas a high troponin and a low copeptin only resulted in 1 death among 26 patients with this biomarker combination. And again, we have a risk reclassification to low risk according to both biomarkers. Now, what does this mean for clinical practice? First of all, should we do routine measurement of cardiovascular biomarkers in patients with COVID-19? I think this is quite a difficult question to answer, and there is a lot of ongoing discussions about this topic. We do hope that our research findings help the clinician in better understanding increased levels of high-sensitive cardiac troponin I, and maybe even guide adequate treatment or management, and especially monitoring in the early phase of the disease. But we do have to consider that these are the findings of one observational study with roughly 200 patients. So external validation is definitely necessary to make definite conclusions. And with this, I would like to end my presentation and thank you for your attention.
Many interesting. In fact, there are a lot of questions. I don't know the order. I don't know which is the first. I don't want to make an error. So first.
Thank you. Excellent paper. It's going to get published. I see it's under review. Congratulations. I did a copeptin paper a few years ago, very similar, and I got spanked at the reviewer who actually made my paper a lot better. So I'm going to give you the same thing they did to me. The most important part here is what they knew in the ER. If in the ER, the patient is going to end up in the ICU, I'll put them in the ICU right now. If they're going to be in the ICU 28 days from now, I don't care. So what I would ask you is how many people went straight to the ICU? Because that means they already knew and the markers wouldn't change anything. But if a third of the patients went to a floor and then went to the ICU tomorrow within 24 hours, they missed it. And the marker would be very powerful because it would make me do something I'm not going to do now. So how many people went to the ER and then to the ICU within 24 hours?
Okay. First of all, that's of course a great point. We had an overall adverse event rate of roughly 25%. And patients going to the ICU on day 1, so on the day of admission to the emergency department, was roughly 7 to 8 patients. So we have a lot of patients that were missed that did not go to the ICU right away. But of course, this is a potential bias as we included those patients as well, where decision was maybe already made upon checking for the biomarkers. But thank you for the input.
Professor Di Somma?
Christoph, congratulations. It's really very interesting. I'm following up what, making echo what Professor Peacock just said, because I'm just asking two questions. What do you think copeptin is mirroring is ongoing physiopathological mechanism there? Because I'm very clear what is going the high sensitive troponin effect. Why you chose copeptin? What was the physiopathological? And then second question, what are you doing as therapeutical decision making? Have these two biomarkers, use beta blockers? So this is an important question, because at the end of the day, from my point of view, biomarkers and now what?
Sure.
That is really my point.
I agree with the second point, but let's start with the first one. So the pathophysiological rationale was that we saw that copeptin is a significant predictor in a plethora of clinical conditions. We looked at inflammatory disease in particular. We have data on pneumonia. We have data on critical illness. We have data on sepsis. And then, of course, troponin being a cardiovascular biomarker, we looked at cardiovascular data. We all know about copeptin and myocardial infarction. We also have data in heart failure. We have data in pulmonary embolism. So we thought that the systematic disease COVID-19 that affects so many organs of our body might be related to copeptin. I already said copeptin, or vasopressin, is of course a stress hormone. It is excreted secondary to hyperosmolarity. So maybe hypovolemia may play a factor as well, because fluid management in patients with COVID-19 is difficult. And this was part of the rationale. But of course, I do not have a clear pathophysiological explanation, as the study was not meant to answer this question. Now, what do we do with our information? And I think that high levels of cardiac troponin are a big challenge for patients in the emergency department. It's difficult to get even an echo sometimes. Of course, risk of infection is there and stuff like that. Now, if we look at our data, of course, single center observational study, we shouldn't make too many conclusions, but maybe we can guide adequate monitoring of these patients. Who needs to go to an intermediate care? Who needs continuous rhythm monitoring? Who needs an echocardiogram right away? And I would say that a patient with high troponin and high copeptin should be worked up in a non-invasive diagnostic way more thoroughly, maybe get an echo, maybe be checked up a little bit more regular, where maybe if our data prove to be correct, we can be a little bit more relaxed. If a patient has a high troponin, maybe it's like, it's not too high, it's just borderline, and has a negative copeptin, because we know that these patients have better prognosis. But direct therapeutic implications, I would not take any from these data.
Professor Mabasa?
Just a quick comment. I'm wondering whether troponin really plays any role, because in fact, it looks like copeptin is in fact making a difference, because when you see troponin negative, copeptin is probably negative, and you have troponin positive and copeptin negative, and everything goes on low risk. Then my question is, did you analyze just copeptin?
Sure.
And my next question is, then you talked about hypoosmolarity, et cetera, which are not necessarily present in COVID-19. What makes really this increase in copeptin in COVID-19 that is not seen in other diseases?
For the first question, we looked at copeptin as a single variable of interest, and we found that the combination was just of more prognostic value. Both biomarkers were significantly associated with the primary endpoint. However, the combination of both yielded superior prognostic information. We also did net reclassification indices. We did AUC analysis. This is all not presented in the short presentation. We just found that the combination was better. And interestingly, in patients with low levels of troponin, the prognostic value of copeptin was significantly diminished. I cannot tell you the pathophysiological reasoning behind it, but this is why. But this is an explanation to the first finding. And the second question, I don't know the specific pathophysiological reasoning why copeptin is high. I just know that it is high in lots of clinical conditions, especially among acute clinical care, and this is why we.
Okay, any question? No, I think time is up, so we can move to the last presentation, and ask to Hakim Burger. I hope is the right pronunciation, from Austria. Okay, this is a very current topic, is a severe myocarditis few days after COVID-19 vaccination, please.
Okay, I hope you hear me now. Okay, hello, my name is Achim Burger. I'm from the cardiology department of the Klinik Ottakring in Vienna, and I'm very pleased to present the case of a patient with acute myocarditis a few days after vaccination against COVID-19 with an mRNA vaccine. So this is the case of a 36-year-old male patient. His previous medical history included an arterial hypertension. He was an active smoker with approximately 20 pack years, and he had a positive family history for cardiovascular disease with both of his parents suffering from premature myocardial infarction. And approximately 48 hours prior to hospitalization, this patient received the second dose of his mRNA vaccination against COVID-19, and he presented at our emergency department with acute chest pain since the day of admission. So here we see on the left side the initial vital parameters of this patient. We see that the blood pressure was slightly elevated with 150 to 80, but with a normal heart rate, a normal respiratory rate, with a good oxygenation without additional oxygen supply. However, his body temperature was slightly elevated. And on the right side, we see the initial ECG. We see that this patient was in a normal sinus rhythm with normal heart rate. However, we see that the ST segments and the inferior leads were slightly elevated. So this patient was further referred to coronary angiography. And here we should see the right coronary artery. And here we see a large vessel, the large right coronary artery. We see that it's unremarkable without any significant stenosis. And also on the left coronary artery, we see an unremarkable vessel here with a small ramus circumflexus, but we don't see any significant coronary artery disease in this patient. So let's have a look at the blood work of this patient. We do see that this patient did have a significant elevation of cardiac enzymes. We see that the high sensitivity troponin reached its peak on day 1 after hospital admission with a continuous decline in further testing. And this patient was then further evaluated with cardiac MRI, demonstrating that this patient had a normal left ventricular ejection fraction and an unremarkable myocardium in the T1 and T2 sequences. However, in the late gadolinium enhancements, we saw that this patient did have significant late gadolinium enhancement in the apex of the heart, the left lateral free wall, as well as anterior and inferior, very much compatible with the pattern of acute myocarditis. And this association between acute myocarditis and the mRNA vaccines is previously described in several reports. And in this context of this topic, 2 very interesting studies from Israel were published very recently. And this is the first study that used data from a large national health service in Israel. They included data from more than 2.5 million patients that received the BioNTech Pfizer mRNA vaccine. And they assessed the incidence rate of acute myocarditis within 6 weeks after the first dose of the vaccine. And here we see the primary result of the study. We see that the overall incidence rate of acute myocarditis is quite low in the overall study population with 2.13 per 100,000 patients. However, very interestingly, we see a remarkably higher incidence rate among male patients compared to female patients. And we see a remarkably higher incidence rate among young patients between 16 and 29 years old compared to patients with 30 years or older. If you look at the clinical severity of the disease on the right side, we see that the most cases were mild and no fulminant myocarditis. And here on this figure, we see the cumulative incidence rate of myocarditis within the 6 weeks since the first dose of the vaccine. And very interestingly, we see that the incidence rate rises more steeply after the second dose of the vaccine. Another very interesting study was published approximately at the same time. They used data from the Israel Ministry of Health of the active surveillance program of the COVID-19 vaccines, and they assessed the incidence rate of acute myocarditis within 6 months after the first dose of the BioNTech Pfizer vaccines, and they included a total of more than 5 million patients. And here we see the results of the study. We see comparable results to the previous study. We see that the overall incidence rate of acute myocarditis is quite low, but similar results, a higher incidence rate among male patients and younger patients. compared to female patients. And also we see a high incidence rate of the second dose compared to the first dose. So to come to a conclusion, acute myocarditis after mRNA vaccination is a very rare event with a very low incidence rate. However, male patients and young patients seem to have a little higher risk. Fortunately, the clinical course is mild in most cases. And most importantly, healthcare providers and authorities should keep encouraging the public for vaccination. Thank you very much.
Thank you. Thank you very much. Any question? Because I have a question for you. Did you do an echocardiography to follow up the development or no of left ventricular dysfunction?
We did before the MRI actually in transthoracic echocardiogram, and it showed a normal left ventricular ejection fraction, no clear signs of regional wall motion abnormalities. And so we proceeded with the cardiac MRI to further assess the left ventricular ejection fraction and to analyze the myocardium itself to check for the typical pattern of myocarditis. Yeah.
Okay, and another thing, I think that the study of New England has a limit that they haven't a comparatory simultaneous group. So I think no consideration between the causality between the incidence of myocarditis and vaccine. What do you think about? They haven't two groups, a comparatory groups without no vaccine and a group with vaccine. So I think that they couldn't do a consideration because it's a retrospective study and they didn't search for criteria of myocarditis and also for the causality of vaccine and the development of myocarditis, I think. But
I believe it's true. It's just observational from a big data set, but there's no causality probably. But I think approximately 1 month prior, there was data published also in the New England Journal of Medicine. In this study, they compared the incidence of patients receiving a vaccine compared to the incidence of patients actually having COVID. And they compared between these two groups the incident rate of myocarditis. And in this study, it was shown that patients who actually have COVID-19 have a much higher risk of acute myocarditis compared to patients receiving the vaccine, which I believe is a strong indicator to encourage people to go on with the vaccination, because the risk of myocarditis is much higher if they contract the virus compared to if they get the vaccine. This is an important message that should be the message of this talk.
Okay, thank you very much. Any question? Microphone, please.
Yeah, that was a really nice presentation, an interesting case and challenging clinically. Did you discuss with the patient whether you thought it was a causal event? Be interested in that. And then secondly, just to speculate, there isn't a right answer, but what do you think the likely mechanism is related to the mRNA vaccine? And why do you think the preponderance of men, which was very striking in that paper that you showed?
Very interesting questions. Maybe to the first point, I think when we discuss this potential link between myocarditis and the vaccines, we have to be very careful not to discourage the public and to not spark fear. We know that if you look at the numbers of people that received the vaccine in Austria, around 65% of the world population received the vaccine. There's a big part of the population that is afraid of the vaccine and doesn't want to get the vaccine. So we have to, I believe, be careful when we discuss this with the patient and keep encouraging to get the vaccine. And to the second point, this is a quite complex and interesting question. I believe it's not yet fully clarified. I believe potentially the mRNA, before it reaches the target cell, might be immunogenic itself and trigger a pro-inflammatory cascade, which might involve autoantibodies that target the cardiac myocytes. But I'm sorry that I don't have a clear answer to this question. Also, it's very interesting why male patients seem to have a relatively much higher risk compared to female patients. I don't have a clear answer to this question.
Okay, last question.
Hello, just a curiosity. Did you find any findings about autoimmunity disease, any labs about this? Because myocarditis in a very young person, excluding the infection.
Check this. We did check this, and we have a standard panel to check for autoimmune disease, but it all came negative. So we think it's just might be this association with orexin. Yes.
Okay, thank you very much.
Thank you.
And thank you, Hakim, for your last message, encourage for vaccination, because I think this is a very, very important message in this moment. And so we leave the other session to Professor Mebasa and Mueller. Thank you very much.
Thank you very much.
Yes, of course.
I guess, Christian, is now the time for the stars. Not us, we are just small players. Sure, you would like to do the first introduction.
So 2 more outstanding presentations, and then you can relax and prepare for the party tonight. So we meet at about 7:30. And now use all your energy and excitement for 2 presentations related to acute heart failure. I would first like to introduce you to Dr. Daniel Gualandro from Brazil and Switzerland. So Dani has been working on cardiac complications following non-cardiac surgery for more than 10 years. I think she was one of the first, at least in this room, identifying how important this setting is. And her work has inspired many of us in the room to follow, to work in this area. And an entity that is just appearing on the scene and being of major importance is acute heart failure following non-cardiac surgery. I know that Josip is very interested in this topic as well. And so, Danielle, you have a lot of excitement for your talk on acute heart failure postoperatively.
Thank you. Good afternoon. Thank you very much for the invitation and for the kindly introduction. It's really a pleasure to be here in person and not behind a computer screen to talk about this very important topic that is postoperative acute heart failure. Can we have this slide, please? Yes. So what's the problem? More than 300 million surgeries are performed annually. And with the advances of the surgical techniques on anesthesia, older patients with more comorbidities are being operated. And mortality related to these procedures is still higher than expected. Cardiac complications are important contributors to these mortalities. And that comes to heart failure, because heart failure is also an epidemic, and the prevalence of heart failure in patients over 70 is more than 10%. And heart failure, especially acute heart failure, is also related to high mortality. So when you put these 2 together, we can see we have a problem. So I would like to start with the chart. This is all the possible knowledge that we have. And this is what we know in green. This is what we know we don't know, and we have to research about it. And the yellow is what we don't even know that we don't know. So to be easier, I'm going to start with what we know about heart failure and non-cardiac surgery. We've known for more than 30 years that chronic heart failure is implicated in worse prognosis after surgery. And that is so that all cardiac risk scores for prediction of postoperative complications includes heart failure. For instance, the Lee score that we use daily that predicts cardiac complications, and also for instance, the American College of Surgeons risk calculators that predicts mortality. But how is the current situation of heart failure and non-cardiac surgery? So in the huge database in Sweden, the authors evaluated the prevalence of heart failure and concluded that 4% of patients submitted to non-cardiac surgery can have heart failure. And if we look at the patients over 65 years old, that could reach 7%. And when you look at emergent surgeries, that gets even worse. We can have 13% of chronic heart failure patients being operated. What's the problem with that? Is that they die a lot. And the heart failure is really related to worse mortality, not even in 30 days, but in 90 days and in 1 year. And if we look at emergency surgery, we can see that 1 year mortality of these patients with chronic heart failure, we don't know if they decompensated or not, is 40% after 1 year, which is really big. And who are these people? So in this other American database of only elective surgery, the authors try to determine who are this population. And they found around 80% of people with chronic heart failure, and the phenotype, 60% of them had HFpEF, 60% of them had mildly reduced ejection fraction, and 22% had reduced ejection fraction heart failure. They also try to look about symptoms, and they saw that the symptoms can vary with 10% and reach 20% in these patients with severely reduced ejection fraction. And then they tried to see if the phenotype had something to do with the mortality. And overall, again, they studied 90-day mortalities. The presence of heart failure was an independent predictor of mortality. And if we look here in the model 2, they try to separate according to the classification of heart failure, but all phenotypes were related to increased mortality. Of course, patients with severely reduced ejection fraction had the worst prognosis. They also did a third model dividing patients with symptoms or no symptoms, but regardless of symptoms, they also have higher mortality, and the symptomatic are the worst. This was confirmed here in this other, it's all database analysis, big databases, but based in ICD codes, basically, of elective non-cardiac surgery, where the authors also described that patients with chronic heart failure, in this case, were new diagnosed heart failure in the last months or symptomatic heart failure. They had not only high mortality, but also a very high rate here in red for all non-cardiac complications, pneumonia, sepsis, and they died more. And that was confirmed by the biomarker studies. So in the last more than 10 years, we have more than 20 studies and 4 meta-analyses that related pre-operative BNP or NT-proBNP with worse adverse events after surgery and also mortality. And the higher the BNP or the NT-proBNP level, the higher the mortality. And that's not more than a surrogate for known or unknown heart failure. But what do you know about acute heart failure? Acute heart failure have been hugely neglected in the last years. And there's practically no studies with acute heart failure alone. Usually acute heart failure is part of the MACE endpoint sometimes, so it's not the main protagonist. In this huge database in the US, they tried to establish what was the frequency and the mortality and the phenotype in patients with that they called perioperative heart failure, because it's a database they didn't know if that was before or after surgery. And they found a high in-hospital mortality of 5%, mainly in the vascular surgeries, but in the orthopedic surgeries, the trauma surgeries, they had an adjusted odds ratio of 7 of dying if they have perioperative heart failure. And when they try to characterize if that was preoperative or postoperative, more than half of the patients here on the right, they could not determine. 5% had acute heart failure only, and for them that was worse. And 28% had acute and chronic heart failure, and 11% had only heart failure. And this is also things that is known for other conditions, but the teaching hospitals and the big hospitals had lower mortality than the small hospitals or the non-teaching hospitals, letting us to know that that would be important. And in this small study, it's small, only 174 patients, but the authors reviewed the chart by hand. So we could have an idea of how frequent it is to have an acute heart failure in patients with chronic heart failure. And they reached 25%. So in this casuistic, 25% of patients with chronic heart failure have acute heart failure after surgery. And the ejection fractions was also related to a worse prognosis, with an ejection fraction less than 30 being the worst. And in this meta-analysis with only 3 studies, that's the condition of this research field. And they try to establish how frequent the association between diastolic dysfunction in the echocardiogram to grade 2 or 3 and pulmonary edema or acute heart failure altogether. But the problem is 2 of these studies had a diagnosis of pulmonary edema only with an X-ray, and only 1 actually used criteria for decompensated acute heart failure. And it was this 300 patient vascular surgery, and they have 20% of acute heart failure. So now I would like to conduct a test. This is what we know. So based on what we know, I would like to know from you, which I will say 2 patients, which one of these 2 patients you think is more likely to develop acute heart failure after surgery. So please, if you're asleep, be awake to vote. So first one, patient number 1 is a male patient, 50-year-old, that comes from elective radical prostatectomy because of a cancer. The patient has known arterial hypertension and no chronic heart failure in functional class 2 from the New York Heart Association, had a left ventricular ejection fraction of 35%, normal coronary arteries, a BNP of 210, and no signs of hypervolemia in the physical examination. That's patient number 1. Patient number 2. Patient number 2 is a 79-year-old male patient that was operated, needed emergency surgery because he was bleeding. He had an hematuria because of Marcumar and an RNI from 8.6. He had previous coronary artery disease with 2 PCIs, a pacemaker, atrial fibrillation, hypertension, and diabetes, but he has also no symptoms, no signs of hypervolemia, and nothing relevant. So now, please, which patient is more likely to have acute heart failure? Patient number 1? Who thinks it's patient number 1? Patient number, raise your hand, please. There's no voting, cool voting tool. Okay, you can vote too. Who thinks it's patient number 2? Oh, majority. Who thinks both of them? Good. Who thinks neither of them? Okay, I know that's high mortality, but I made a lot of pessimistic people. Well, what happened then? Patient number 1, he was operated, no complications, and was safely discharged. Patient number 2. Patient number 2, he had on the 6th day, he had dyspnea, he had clinical signs of volume overload, high BNP, and post-operative acute heart failure. And when you do detective work, what happened with patient number 2? So we can see here that he was operated here on a Friday, and then he was in the he went directly to the surgical ward, and then he starts receiving fluids, and then he had a chronic myocardial injury, then he had a perioperative myocardial injury, and then the surgeons were concerned, what do I do with the anticoagulation? Should I call the cardiology to ask? But then on day 6, he had a shortness of breath, and then they asked for a consult for the internal medicine physicians. And when the internal medicine physicians reached the patient, he had clear signs of hypervolemia. He was 7 kilos in plus since admission. He had an NT-proBNP of 7,945, so he had acute heart failure. So that's what we don't know. We really don't know what's the incidence, or the risk factor, or a better characterization of patients with post-operative heart failure. So we always have to, that's why we're here. What can we do about all the stuff that we don't know and that we know we don't know? We can do something about it. So here we did some analysis to try to address this topic. So we used the Basel PMI study, which is a prospective observational study, including patients with, if there are more than 65 years old or more than 45 years old with atherosclerosis signs, where you do troponin screening pre and post-operative. And we also adjudicate all outcomes, including acute post-operative acute heart failure. Then we found an incidence of overall 12.5 of acute heart failure. But if you look at the bar charts here, there are the blue bar chart, we can see that patients in orthopedic and vascular surgery had a higher incidence, and patients with urgent surgery, they reach 4.5% incidence. And more interesting, half of these patients, they had no previous history of heart failure and new cases. And in this case, in these patients, 72% had preserved ejection fraction, and only a minority had reduced ejection fraction. On the other hand, the patients that had chronic heart failure, they had a little different phenotype. Most of them had at least mildly reduced or reduced ejection fraction. And mean age was 79 years old, and 12% had chronic heart failure. From these, only 10% develop acute heart failure. And when we look here at the bar chart at the right hand side, we can see that 50% of the cases happen until day 6. And that's exactly when our patient had his event. But if you see, there's a continuous cases until day 30. We also found out risk factors to acute heart failure, and our patient number 2 had practically all of them: age, atrial fibrillation, chronic arterial disease, diabetes, chronic myocardial injury, all of them. And the patient number 2 had chronic heart failure. We also tested if the revised cardiac risk index is useful to predict acute heart failure, and we found an area under the curve that is similar to predict all outcomes. So it's not so bad. You could use that. And what about the mortality? I think that's the most impressive thing. The 1-year mortality of these patients was 44%. And when we look at a subgroup, so which is worse, to have acute heart failure as a first event or to have a decompensation of a chronic heart failure, patient with a decompensation of heart failure is the first curve, that is a more dark red, 52%, against 36% for patients with first diagnosis from heart failure and 21% in patients with chronic heart failure. They also had overall more hospital admissions. 15% had more hospital admissions in 1 year. So we could conclude that we expanded what we know a little bit, but what we know is that chronic heart failure is associated with higher mortality after non-cardiac surgery. If you have symptoms, if you have a low ejection fraction, or if you have a high natriuretic peptides before the surgery, it's all even related to worse mortality. The incidence of acute heart failure is around 2 to 4%, but these patients, half of them has new diagnosed heart failure, and we can do something from this patient. We can do something for prevention, which is taking more care of patients with with risk factors, and maybe watching them more carefully in the post-operative. But also, if we do a diagnosis of heart failure, we have to treat them, or we have to give them follow-ups more often and optimize their medication, because they have much higher mortality than a patient that is discharged from the emergency department with an acute heart failure. The mortality is a lot higher. And with this, I would be open to what we don't know, to questions. I would like you to help me with that. And I would like to thank Christian and thank also all the researchers in CRIB that make possible to make this slice of the pie of what we don't know goes to what we know. Thank you.
Great presentation. Thank you very much, Dani. I think a lot of questions. Of course, the gentleman in the first row, they fight out who is allowed to start. So Joseph, one.
Thank you, Daniel, for this excellent presentation. Did you exclude the myocardial injury of the patients with elevated troponin, or you include also?
No, they are all included. Like 20% of the patients with postoperative acute heart failure, they had also acute myocardial injury that we adjudicated to be due to heart failure. But we do all the workup with...
But not myocardial infarction?
No, no myocardial infarction. That was excluded, yeah.
Other questions?
maybe you can. Are all the surgeries equal? I mean, neurosurgery, GI tract, how in the literature and your experience, orthopedic surgeries are known to carry much more old patients? Is it more there that we see the problem, or it's really anywhere?
What is it? It's mostly the orthopedic patients mostly are the worst, followed by the vascular patients. Because usually when you talk about myocardial infarction, is the vascular patients worse because they have all the atherosclerosis profile. But for heart failure, I think it's most the old people with risk factors and preserved ejection fraction that they compensate after surgery. Then the orthopedist is a good field for that.
Yeah, the ladies first, Salvatore, if you like. There is a young fellow from the
fellow.
jury.
Thank you very much, Alex. Very nice presentation. Is there any difference according to sex in the heart failure following surgery?
No, we didn't find any difference regarding to sex. There was no difference.
Professor Di Somma.
Terrific job, Daniel. Fantastic. Thank you. I appreciate it very much. So we come to an hypothesis that we should do BNP or NT-proBNP before the operation. That should be a way, because what is impressive that only 20% of people with chronic heart failure develop acute heart failure, correct? From your study, something like that? Very few.
In our sample, that was 10%.
Even less, even less.
Even less. But for others, like for this vascular surgery, for others was like 20%.
So the question is, but you know, in the second case, you didn't show up the BNP value. Do you think that if we do routinely BNP, can we detect these people without chronic heart failure have the risk to develop acute heart failure?
Mm-hmm. Yeah, definitely. I think we have a lot of evidence that we can recommend that this is recommended, for instance, in the Canadian guidelines already, that we could do NT-proBNP or BNP for risk stratifications, for instance, in patients with more than 65 years old, because we are aiming to detect the undetected heart failure, because the problem in the perioperative is that the patients that are old, they are sick, they don't walk, so they have METs under 4, so they think they don't have symptoms, but they could have undiagnosed heart failure. That's, I think, it's the big problem. And also the older people, sometimes they think that they are tired because it's normal, because they are getting old, so they can do less stuff, and they think that they can do less stuff because they are getting older, and this could be already a symptom of a beginning heart failure, and that with the biomarkers we can detect that.
Professor Oscar Miro, yeah, who this year you saw that he's not talking about the Messi score.
Okay, no, all yours. Thank you, Daniela. Just a question: how many cases of acute heart failure do you think could be attributed to the aggression of surgery against a frail myocardium, and how many can be attributed to a failure in the management of post-operatory by post-operatory doctors? I mean, because the second one can be avoidable, right? The first one maybe will remind whatever you do, but the second one is avoidable. So how many patients, or which part of this slice you think can be avoided by a good management?
I think we have two different phases. I think we have the early case and the late case, and I think they have different mechanisms. I think the early case I related to what I showed, like the patient has a lot of risk factors, go to a surgical ward, receive a lot of fluids, is like a iatrogenic acute heart failure, and then nobody noticed that it's slightly decompensated until he's really decompensated. So this could be avoided by the better fluid manager, a better fluid evaluation if we don't have enough internal medicine physicians, a BNP. Because in this case, for instance, we perform the screening with troponin. And when there is a perioperative myocardial injury, we get an automatic conceal. an automatic cardiac consultation. And we make a lot of acute heart failure diagnosis in these consultations. And nobody had called us. We just go there spontaneously because troponin was elevated. And then we see, troponin is elevated because the patient is in completely decompensated heart failure. So I think biomarkers could help that. And I think that would be avoidable, a better internal management in this situation. And a second problem that is, I think, the late cases are the patients with the reduced ejection fraction, because then what happened is that sometimes people stop the medication and then nobody remembers to take back the medication, and then at least in that case, sometimes they go to the rehabilitation or they go somewhere else to get rehabilitated, and they don't have a follow-up visit with the general practitioner or with the internal medicine physician, and these medications are not given back or are not up-titrated, or they have had optimized ACE inhibitors, beta blockers, and then after surgery, everything goes down, and they have little doses, and this is not up-titrated, and this leads with the time with a higher mortality. So I think I think the key for these patients is to have a perioperative team, because we have already heart team, endocarditis team, all team. I think a multidisciplinary perioperative team was what could solve this problem. Because if we have like surgeons, internal medicine physicians, and anesthetists working together, we can get this. Because the problem is that the anesthetists, they go before surgery, and then the job are done. Then gets to the surgeons. And that's why we need this integration.
We are not going to start talking about the surgeons. Thank you so much.
Thank you.
Thank you so much. Now, it's really our deep pleasure to have a friend, a long-lasting friend, Professor Joseph Massip. Earlier, I talked to you about beta blocker, ACE inhibitor, ARNI, SGLT2 inhibitor, and Professor Massip is going to tell us more about acute heart failure in the last ESC 2021 guidelines. Pointer does not work, Joseph.
Okay. Thank you, Alex. It's a pleasure to be here again after nearly 2 years without meetings. And I'm going to give you my personal view of the guidelines. We are preparing a paper for the ACBC. It will be an educational paper, and probably after 1 month, I could give you a more precise position paper. But now I'm going to give you my personal view of the guidelines. Okay. First of all, it is fine. It's fine because we are Professor Memasa, and also Christian and me have been working in these guidelines. And unfortunately, I arrived 2 hours ago. I couldn't see and I couldn't hear what Alex presented to you.
Joseph, I didn't do anything. I say, please wait for Joseph. He will speak about everything.
It's a pity because you are really an expert. But just remind that this seems to be UK guidelines, because nearly 32% of the authors were from UK. It's a post-Brexit guidelines, no? Alex?
If it have been in French, we'd have been more French people.
Okay. Okay, wait. Okay. Let's go. First of all, I'm going to talk about the diagnosis. And in fact, we should distinguish between acute heart failure and decompensated heart failure, because and the definition is a patient that is seeking urgent medical attention that results in unplanned hospital admission or emergency department visit. We will not be acute heart failure patients that have mild decompensation that are managed in the outpatient visit. And if we see what the American guidelines say about this, they don't have a specific part of acute heart failure. They only have a part of the hospitalized patient. And we will see some differences within the two guidelines. First, I think this is too far, and the other is difficult to see. Okay, I will see this. Let me put in this position. Yes. First of all, about the diagnosis. No, it is okay. The problem is, if I see this, I need glasses, and I see this, it will be better for me. If you
can we turn this?
If you forgive me to be in this position. Okay, let's go to the diagnosis. I want to show you the difference between in the guidelines, heart failure diagnosis or acute heart failure diagnosis. You see that the peptides are in a better position when we are talking about diagnosis of a heart failure in general. And we see that in the acute heart failure is in the second position. It is true that probably if we take into account all of these tests, electrocardiogram, pulse oximetry, echocardiography, or HSA, we have easily the diagnosis. It is true. But look at this. They say diagnosis of new cases of acute heart failure. When we talk about new case, I think is obligated to use peptides. And also, if you see this, when they talk about peptides, they have downgraded the peptides because they say it should be considered. This is 2A, is not 1.
This was an error. This has been corrected. This is an error in the table. It has been corrected.
But I wanted to say that we sent a letter, you and me.
It has been corrected. It was an error.
But it didn't answer me. I answer you because
it has been corrected.
Because Joseph, you are not English. If you were from UK, you would have had an answer.
Yeah, okay, you are right. But Americans have class 1A just for diagnosis and also for prognosis. Therefore, we should put peptides in acute heart failure for all patients, the same as troponins, and even more if there's the new acute heart failure episode. And regarding the phenotypes, fortunately, we have these 4 phenotypes. I've been using these 4 phenotypes for my students for the last 3 years. I'm happy with this classification. Acutely decompensated heart failure, acute pulmonary edema, isolated right ventricular failure, and cardiogenic shock. Fortunately, we passed the previous phenotypes of the guidelines in 2016 based exclusively on congestion and hypoperfusion. And these guidelines were based on the American guidelines, and which was recognized by one of the authors of this classification that most of the patients are in group B, wet and warm, and say 85%. And let me talk about these 4 forms. And when we say warm and dry, is a patient without congestion and hypoperfusion. This patient has no heart failure, because and what happened with the other? I think this is true because there is congestion and hypoperfusion, but if we only pay attention to congestion, we cannot distinguish congestion in the lungs or congestion in the body. And this is what I think that is not useful, because we will give warm and wet just diuretics and the other inotropes or vasopressors, and because that does not distinguish between lung congestion and body congestion. And this is the real classification: warm and wet, cold and wet with cardiogenic shock. Very few patients are cold and dry. These are patients with very advanced heart failure. They are hypotensive, very well treated. They have more hypotension than congestion. And the main alterations are it is true there is systemic congestion with volume overload and maldistribution, and also this hyperperfusion, but also the third component is pulmonary congestion, and this causes acute respiratory failure. And this is what I think that when we just pay attention to wet and dry and on colon, we lost the perspective of respiratory failure. It's important respiratory failure. We judge that nearly 1/3 of the patients had respiratory failure based on registries that they had blood gases. But in fact, when we look at this with Oscar Miró in the Spanish registry with nearly 20,000 patients right now, and we calculated the ratio of SpO2 FiO2, and when it's lower than 428, this means that it will be lower than 90% of saturation. And we found that nearly 40% of patients have acute respiratory failure. And if we took lower than 93, it is nearly 50%. It's important. Respiratory failure. We should pay attention to this because this needs a different treatment. And when I look at the American guidelines for oxygen or for ventilation, any reference in the guidelines, in the three guidelines, 2013, 17, and 19. How can it be? Because Americans is the best. They are the best researchers, and it's the first country in the world, and they don't know that the patients with a heart failure have a respiratory failure. Let me be provocative, Frank. Okay, let's go again for the 4 phenotypes.
No, you are not from UK. You will not have the microphone. Okay. Let's go to this 4 phenotypes, because the guidelines is addressing particularly every phenotype. The first is acute decompensated heart failure. In this case, they don't consider oxygen or SpO2. Probably they believe that all the patients with respiratory failure are in the group of acute pulmonary edema, but we will see that it's not true this, but they don't consider oxygen in this algorithm. They recommend to use diuretics in patients with hypoperfusion, and in our group we have been discussing for years if we have to give diuretics in a patient with very high potency or is with a low perfusion. We should first improve the hypoperfusion, but it is not really something that is strong. And also they don't mention that more than half of the patients have hypertension, and probably they would need vasodilators. And they speak about inotropes in this group of patients of acute decompensated heart failure, but they don't talk about oxygen. Regarding the phenotype 2 is acute pulmonary edema. They use our proposed diagnostic criteria. Patients with acute pulmonary edema are those with dyspnea, with orthopnea, respiratory failure, with hypoxemia or hypercapnia, with tachypnea with more than 25 breaths per minute, and increased volume of breathing. This scenario is a patient with really shortness of breath, and we can distinguish clearly this patient from other patients that are tolerating supine position. And they say 3 therapies are recommended. First is oxygen given in a way of CPAP or pressure support or high flow nasal cannula, and diuretics as a second, and the third vasodilator if they are hypertensive. But when we go to the algorithm, we see that they say oxygen or ventilatory support. It may be because they consider that all patients with a respiratory failure are in this group, but this is not the case
of the clinical picture that they describe as acute pulmonary edema. And also they put the cutoff for 110, which is, we consider that probably with acute pulmonary edema are less than 20% of the patients. And they should put here non-invasive ventilation directly. And just discussing with this 110 or 100 could be discussed. And we analyzed how often is pulmonary edema in the radiograph. And we analyzed 2,700 patients with acute heart failure. And we saw that the interstitial edema was in 23%, alveolar edema in 15%, pleural effusion in 37%, and 62% showed vascular redistribution. We found abnormalities in most of the patients, but which of these abnormalities are really depicting what is a pulmonary edema? I think it's a clinical diagnosis based on some criteria, is not based on the radiograph. And for this reason, we should define exactly what is acute pulmonary edema. And probably most of the patients that have mild respiratory failure should go to the acute decompensated heart failure. Regarding cardiogenic shock, is quite appropriate, but they put this classification regarding the stages and the severity. And I think this is good, but this is in the supplement. But most of the people do not see the supplements of the guidelines. And for this reason, we lost the opportunity, try to be more daring and try to address the therapy regarding the stages, which is more challenging. As we made in this paper published last year, we talk about cardiogenic shock, whether it's refractory or just using this beginning, classic, deteriorating, or extremis. And also in this paper, we stressed clearly the importance to have a very good network with patients for cardiogenic shock, and also the heart team. We need a cardiogenic shock team. Together, we investigated this in Spain, and this reduced the mortality and also increased the number of procedures and also the prognosis. And regarding phenotype 4, I'm not going to speak about it, but at the end of these phenotypes, they put this algorithm for the management of suspected acute heart failure. I agree with this algorithm. It was in the previous guidelines that has been improved, but adding infections and tamponade, which when we say CHAM, now is CHAMPIT, and this is okay. Perhaps I would say patients with cardiogenic shock on significant respiratory failure should go for ventilatory support or for pharmacological support, intravenous or mechanical devices. But if they have mild respiratory failure, they don't need to go to the intensive care. They don't need to go to, they can be managed in the emergency room just with oxygen. And when we see the recommendations, I think they are appropriate, but usually people retain in their mind the algorithms. The images are more clear, and we should fight for better algorithms, more adapted to what is the reality. And I like this algorithm for the management of diuretics. They include this urinary sodium, urinary output, and this is new. And finally, when we look at the clinical course, this is what the Americans have in their guidelines, which is quite good, but it's just which are the targets. But I think we should go for another approach. First of all, the guidelines just dedicate a short paragraph for the pre-hospital. It is very, very, very short, and they don't dedicate any comment about emergency department. And think that all patients pass by emergency department. And in this study carried out by Oscar Miró, 15% of the patients arrived with a medicalized ambulance, 38 with the ambulance classical, and 47% arrived by themselves. And look at the treatment. When they arrive by themselves, there's just 3% received some treatment, or they took some specific treatment. But when they arrive by the ambulance without doctors, 57% receive oxygen. This is a classical, because even all the movies, when we see the team, the ambulance, they put oxygen. But this is logical, because most of these patients have shortness of breath. And finally, when there is a doctor, 73% receive oxygen, 30% diuretic, and 4.5 non-invasive ventilation. This means that all of this treatment should be started as soon as possible, and they should pay attention to this. And also the treatment that patients receive at the emergency department is crucial, because you see that 25% of the patients are sending home. In some countries, even more. This is in Spain, what they have. And we should apply some risk scores. We should decide if the patients have to be transferred to the ICU, or the patient should transfer to a hospital ward. Probably the guidelines are made by cardiologists. Many of them do not see really critical patients or acute patients. And I expect that next guidelines will save all of these inconsistencies. Thank you very much for your attention.
Joseph, thank you very much. I think we have time for 1 or 2 comments or questions on this topic. Okay, so I think you made it clear what you've confirmed, and some areas where you think improvements are needed. And I think that's highly appropriate. Other than nothing is perfect, and I think you nicely highlighted some of the points. Perhaps we use now the opportunity to highlight that Joseph is not only the last expert on the program today, but he will also be the one who is chairing the first session tomorrow. In order to allow for a good party tonight, the program tomorrow will only start at 9 o'clock. So there will be ample time for sleep and breakfast. And we expect you back at 9 o'clock tomorrow. I think now the question and comment in French from Frank.
Oui. Yeah, so you were teasing me about the American guidelines.
You were teasing the United States of America, not you.
I'll take responsibility for that. But 2017-19, the prior one, I guess 2014, if you look at the who authored that, and you hinted at this, it's a bunch of cardiologists do academic medicine. And if that's all you have, that's all you get. And the Americans have been very slow in adopting anything more than that slice of pie. In the last couple of years, they've gotten on board on this. And so we've completely changed the way guidelines are written, but we're still waiting. The 2021 guidelines for ACS should come out. And there's a good 10 emergency docs involved in that. And there, like 50 people write these guidelines. So that's a way different. It's a lot more early emergency department risk stratification, discharge patients who don't even go to the hospital. And that was never happening before. And so that's always the risk when you make a guideline, is if you get a bunch of people who are just GI docs, guess what you get? So you need to have the whole spectrum that touch the patient, from Oscar in the ambulance all the way to whoever's managing them in the clinic at home. And if you forget any one of those people, you end up with weak guidelines.
Thanks very much. Are there other comments? Okay. Then thank you so much, Joseph. Then I'm talking under the control of Valeria. 7:30 the dinner. Can you maybe, Valeria, can you come here and tell us what is the dress code? At what time we should be here? What music the orchestra will play? I mean, everything to push us to come to the dinner tonight.
Tonight is casual, completely casual. So at 7:30 there will be a wine tasting and then an informal dinner. So
And
we wait for you.
Can we use
upstairs.
this moment to thank Valeria, because you did a great job.
Thank you. Thank you very much.
See you tonight and here tomorrow at 9 a.m.